Welcome to Built Wales and this the 9th annual Rural Health and Care Wales Conference. Good to see so many in the room this morning and colleagues online. I think you can see a few of them on the screen to my right. I think we have nearly 60 delegates registered to attend in the showground here both today and tomorrow. And then we've got double that number registered online. So we've got quite a degree of interest for what promises to be a really inspiring and exciting 2 days of discussion and talks. I really do want to thank everyone for taking the time out of their busy schedules to join us. And I'm really looking forward to some of the discussions we're going to have over the next 2 days. Just a word of introduction. My name is Keith Jones. I'm the Programme Director for the Mid Wales Joint Committee. I took up that role early this year. And one of the key privileges that responsibility brings is the opportunity to chair the Rural Health and Care Wales stakeholder group and, as importantly, this year's annual conference. I'm really keen to get into some really inspiring conversations over the next 2 days, and I'm really grateful to be here with you all. Now, for those who may be less familiar with its background, Rural Health and Care Wales, or RHCW as we refer to it, was formed back in 2014 as one of the key recommendations of the Mid Wales Healthcare Study that was commissioned by Welsh Government. The resultant report, the Longley report, as it's referred to, after the work of Professor Marcus Longley and his team, made a number of key recommendations. One of those was for health and social care organisations to come together and plan for some of the unique challenges of delivering health and care in rural Mid Wales. But the report also importantly called for research and innovation and exploration of a range of transformative and innovative ways in which to deliver health and care in rural areas such as Mid Wales. And so the Rural Health and Care Wales was born. Now, for those of you who were present last year at last year's conference, you'll recall that reflected on the progress that's been achieved over the last 10 years. And it was a celebration, I guess, of what has been achieved and some of those strong foundations that have been laid between health and social care sectors within this part of Wales. And I think it's fair to say the work that has been achieved over the last 10 years is proving to be very much the model that's now being replicated in other parts of Wales. That's a tribute to yourselves and others who are not with us today for the work that is being progressed. Now, over that time period, the annual conference has evolved into a 2-day event, and certainly that's the case this year. And I guess that reflects the level of interest in the work that's being progressed by RHCW and the work of yourselves and our respective organisations in this particular space. But it's also reflective of the increasing and growing number of submissions and presentations and talks that have been submitted for consideration and at our annual conference. And certainly this year is no different. We've got showcases from excellent work that's going on within Wales, across the UK and indeed overseas as well, and more of that in a second in terms of colleagues who are joining us over the next 2 days. This year, I think we had 54 submissions, and my hat goes off to the panel who've been involved in assessing those submissions and filtering them to determine those that can be fitted into our programme for this year's conference. Apologies to those whose their presentations or their submissions have not made it into the main plenary sessions this year, but you'll notice around the room we here in Built Wales we have a number of poster presentations reflecting some of the excellent work that's going on in this space. So over the next 2 days we have 9 plenary sessions, we have 18 breakout presentations, As I said, we've got 27 poster presentations around the room, and we've also got some exhibition stands here and in the international building across the way. So there's a wealth of work for us to reflect on and have a discussion about as we go through the programme for today and tomorrow. Now, as you probably noted from this year's programme, the theme of this year's conference is innovation and improvement, advances in the delivery of rural healthcare and wellbeing services. And we've got a pretty packed agenda to get through over the next 2 days. We'll be looking at the role of health and care integration in a rural setting. We'll be having a particular focus this morning on some of the workforce challenges that are unique to a rural environment and possibly exploring some ways in which they can be mitigated. Really importantly, we'll be exploring the role of communities and unpaid carers in delivering care and health services in a rural setting. We'll also look at the digital agenda and the opportunities that brings. And also, and probably maybe more so tomorrow, we'll be looking at the role of prevention and some of the social and non-clinical interventions that are so important and critical to health and care delivery in a rural setting. So, as you have noted there's quite an agenda for us to work through. To help us work through that in a somewhat structured way, we're going to sort of split the theme of the next two days. So today will be focused more on clinical delivery and an educational focus, I guess. Whereas tomorrow we'll look a bit more at some of the social determinants and non-clinical interventions that are so critical. In terms of today, this morning, we'll hear a bit about some of the challenges of developing and sustaining primary care services within an environment such as West Wales. And we've also got an interesting conversation around how we can improve access to medicines in geographically isolated rural environments. This afternoon, I'm really pleased that we'll be rejoined by our friends from Alberta in Canada, who will share with us some really excellent examples of multi-agency, integrated, community-based working in a rural environment, and looking at some lessons maybe we can reflect on in a Welsh context. But we'll also hear of a more local example from Lampeter of some community-based teams who are working very much in a multi-agency way. And then later on today, we'll also be joined by the leaders of 3 of the main healthcare organisations serving the population of Mid Wales, and they'll be sharing their thoughts about not only successes thus far, but really the journey ahead of us. Interspersed between all of that, we'll have some excellent breakout presentations as well, and some really inspiring and interesting and exciting topics for us to get our teeth into. As well as listening and learning from our speakers and presentations over the next 2 days, though, I really want to encourage everyone involved to really engage in what is an interactive opportunity this year. Certainly feedback from previous conference evaluations has pointed to the really rich and valuable opportunity that the informal networking opportunities provide to delegates in the conference. So please reach out to those around you. We've got a delegate list that's drawn from a very diverse and broad background, everyone with an interest in the delivery of health and care in a rural setting. So I'm sure as you speak to colleagues through breaks, through the lunch periods, I'm sure you'll have an opportunity to share experiences and learn from each other. It's also important for me to thank the RHCW team, both Anna, Michelle, Lottie and Marie, for their incredible work in organising, again, this year's conference. It's a huge undertaking. It takes many months of planning. So just before we start the main part of the day, I'd really appreciate it if certainly within the room and those online could show their appreciation to the RHCW team. Okay, there are, as I'm sure you'd expect, some important logistical housekeeping messages I need to share with you. Possibly, firstly and most importantly, I guess, as you'll all be aware, today is the 11th of November. It's Remembrance Day. So we will be pausing our proceedings at 11 a.m. I'll invite everyone to join us in observing 2 minutes silence in memory of those who lost their lives in service. So I'll remind us of that nearer the point, but just an advance notification of that at 11 a.m. Now, Anna, I don't think we've got any fire drills planned today. So if the fire alarms do sound, then let's assume they are for real. In terms of fire exits, they are at various parts of the side of the building here in the showground. So there's one there, one on the back corner, similarly one on this side as well. If indeed we do need to respond, then please all gather in the car park area just outside the International Building, if that's the case. Not expected, but just important for me to mention that at the outset of the day. Toilets, you can see there are some to my left here, and again, we've got some facilities over in the International Building as well for those who will be attending some of the breakout sessions over there. As in previous years, the conference is being broadcast live, yeah, and will be recorded. And once we finish the 2 days, the recording will be posted on the RHCW YouTube channel, either for you to catch up on any particular sessions that we haven't missed. Mindful that we're asking you to choose specific breakout sessions you want to attend. So those you missed, then you've got the opportunity to watch those back on the YouTube channel. And just probably important for me to check that everybody's okay with that. And if you've got a particular issue with being recorded, then please reach out to a member of the RHCW team who will accede to your wishes. Yeah. Similarly, we do intend to take pictures through the next 2 days. It's important that we do celebrate this event and the work that everybody's doing. So again, if you've got any particular concerns with that regard, then please reach out to the RHCW team to make that known. Now, as you'll note from the screen to my side, we have a mix of in-person and online colleagues joining us, and the same applies to our presenters. We've got some that will be with us here in Builth Wells, and some will be presenting online. So I'm advised that in previous years that can sometimes lead to a few technical glitches. So if that is the case, then please beware. Please bear with us, and I'm sure we'll resolve those issues really quickly. Just as a courtesy, I guess, there to make that process work smoothly, can I ask that when presenters are delivering their talks and their discussions, either through the plenary or breakout presentations, if I can ask colleagues who are online to mute yourselves and put your cameras off during those presentations, yeah. And similarly, for those in the room, just make sure your mobile phones are either off or on silent, yeah. We're really keen for, as in previous years, I guess, for this conference to be as interactive and engaging as possible. So we really will be encouraging questions from delegates, both in the room here in Builth Wells and online, following each of the presentations that we'll be listening to this year. Yeah, just a word on the arrangements for that. So for colleagues who are online, I think the methodology is for you to use the chat function within Teams channel or the Q&A box, yeah, or as I'm sure you're all familiar now, just raise your electronic hand. For those in the room, the more traditional route, just pop your hand in the air, and then we'll acknowledge you and allow you to interact. In terms of the way the questions will work, I think in fairness to the presenters, to avoid disrupting the flow, we're aiming to keep the questions to a period at the end of each presentation. And once you've signalled your intention to raise a question, we will have roaming microphones So just wait until the microphone arrives at you, with you rather, and just let us know who you are and introduce yourself before posing your question. Yeah, so hopefully that will work quite smoothly. It's important for me also just to have make a few comments about the format of the day. Yeah, I think some of this has been communicated by the information you've already received, but it's worth me just bearing that out and repeating it again. So we have three main locations here in the Royal Welsh Ground for the event of the next 2 days. The room we're in currently, the Montgomery Pavilion. This is the location where the main plenary sessions will be delivered and some of the breakout presentations, and I'll get to the detail of that in a second. The other breakout presentations will be delivered in the international building across the way, both on the ground floor and the first floor. Yeah. So as you're probably aware, you've all been invited to select which of the 3 different talks you wish to attend during each of the 3 separate breakout sessions today. Yeah. And we'll work through the mechanics of how you access those as we get to each particular session. Yeah. For those online, I think you've been given information as to how you access those breakout rooms through the Teams channel. For those here in North Wales, it's going to be a physical walk if you're going to attend the breakout sessions over in the international room. After each breakout session, for those online, just re-click the link for the main conference and come back into the main room. Obviously, for colleagues here in Bill, and it's a walk back into the Montgomery Pavilion. Yeah. Now, you may have noticed around the room we have a range of posters, 27 in total, and the eagle-eyed of you will have noticed each one has been numbered 1 to 27. We are intending to run a bit of a competition this year, yeah, and we are really keen to get your feedback and to help us further evaluate and select the top 3 posters and poster presentations, and we will be looking to offer a special award to the overall winner. I think in your conference bags for those delegates in the room here in Belfast, you have been provided with a scoring sheet, I think. So during the coffee breaks and the lunch breaks, please avail yourself of the opportunity to look at those posters. And I think we do have quite a number of the authors of those with us in the room today. So please take the opportunity to chat through some of their work that's reflected on those posters. We are asking you to evaluate those posters against 4 main criteria: quality of information and research, the relevance to our rural health and care agenda, the overall design and effectiveness of the posters, which is always important, and also the extent to which they focus on innovation and the future. Yeah. So really, we'd be really grateful if you can support us in that effort in helping to evaluate the posters that are on display. Also important, and I think you may have certainly, for those who attended the conference this morning, you have been advised of the translation facilities that are available. So for those in the room, we have headsets. Yeah, if you haven't yet been able to access a headset, again, please reach out to the RHCW team, and they'll make the necessary arrangements. For those online, I think you've got, in the Teams function, you'll have that opportunity to select the translation language, etc., and you can follow that through. Yeah. I'd also just want to draw your attention, and I can see Sean sitting over there in the corner. We've got colleagues from the Welsh Ambulance Service with us today, who will be, certainly through the breaks, I think this morning and this afternoon, running some demos on CPR. So if you've got any questions or learn anything more about that, then Sean is the person you need to speak to, and I'm sure she'd be delighted to engage with you at that point. Okay, so I think that's the housekeeping notifications done, and I think without further ado, I'm really keen now for us to progress with the programme. And to start us off, I it's important that we just mark it with an official opening. And I'm really grateful and we're really pleased to be joined this year by Dr. Chris Jones. He's the chair of Health Education Improvement Wales, and I'm sure for those who know him, he needs no introduction. Chris is a very inspiring and entertaining speaker, and we're grateful to have him with us this year. Through his career, he's undertaken chairmanship roles in CONTAF and for the NHS Wales Confederation, and has spent a long career, of course, as a practicing GP. And importantly, of course, back in 2007, he was awarded the OBE for services to healthcare. So, colleagues in the room and online, I'm really grateful if you join me in showing the appreciation and welcome for our official opening speaker today, Dr. Chris Jones.
Bore da pawb. Gallet ti clywed? Can you hear? It's a great pleasure to be invited to something like this. Yes, I have had a long career in the NHS, but most importantly, bachgen bach o Machynlleth ydw fi. I'm a boy who was brought up in Machynlleth. I still return to Machynlleth. I've got loads of relatives throughout Powys, and I hear. The first thing I'd like to say is that when I looked at the programme for this conference, I thought, wow, what a difference. This conference has clearly grown and has clearly matured. The thing I've always found valuable in my career is do what you need to do today, really plan for the near tomorrow, but actually keep your head up and look at the future. Now, rural healthcare is a very interesting, wide-ranging, and sometimes challenging area to work in. But it is part of a whole system. And of itself, the care that can be given within rural communities is also dependent on larger centres. So for me, the relationship and the balance is really important, not just for good care, not just for really good experience for patients, but it's really important that it's very clear to give assurance that services are available. And I think equitable care for everyone in Wales is part of the rural health agenda. Now, rural health and care, and I think the and care bit, is perhaps the emblem that rural health and care collaborations like yourself can actually lead. And I think it's the closeness of the care and the health issues that make it really interesting. I chair an organisation that is dedicated and focused on developing the workforce and providing the pipeline in the workforce. So when I first spoke at this conference some 7-8 years ago, it was very clear that there were challenges, and looking today, those challenges are still there, and there are newer challenges. We've all come through, I think, a very difficult period where we've had the COVID, and COVID has been a hell of a thing to experience, but it has fundamentally changed people, their expectations, and the way that they, in particular, want to receive education and training. My view is that we are only in the foothills yet. We haven't got up to the dizzy heights of Cadair and Snowdon. We're still in the foothills of developing what that should be. RHCW is at the moment developing an education strategy. And I think we will see the impact, for instance, of technologies like AI absolutely fundamentally changing the way that education and training is provided. One of the risks that any professional has of working in rural communities is the tendency to professional isolation. Look at us today, we're in a hybrid conference. There's some of us here in Cardiff recovering from a recent dose of COVID, and there's some of us in the room. We're using technologies today that 6-7 years ago we wouldn't have even thought about. So look, I can say to you today that there are more people in training in health subjects than ever before in Wales. We've got a new medical school in Bangor, and we've got a new nursing school, or a relatively new nursing school, in Aberystwyth. The task we have to make sure is that the people who come through those systems, that we have work for them, and that we are able to use their skills and not lose them out of Wales. The future of rural healthcare, I believe, depends on collaboration. It depends on digital transformation. And I think it depends on something that I think rural communities are well up for, and that is community empowerment. That community empowerment needs to face up to how do we deal effectively with prevention, and how do we deal with digital exclusion, and I think health literacy. Of all the things that we can do that would benefit the vast majority, I think digital inclusion and health literacy would be a huge benefit. Finally, I'll say to you, I think this conference is a chance to share best practice, yes. It's a chance to articulate some of the challenges. But most importantly, I think it's a chance to begin to shape the vision and to start to put our foot forwards rather than contemplating everything is impossible. And I think the art of the possible is something that the rural health care system probably can help the rest of Wales, probably the rest of the United Kingdom health and care systems. Care close to home goes to the heart of what it feels like to be part of a rural community. I would say that needs to be the necessity for everyone, not just people living in outer Machynlleth, but people living in cities. Being part of a community is really important. I think your communities have got a lot to teach as well as to learn. Thank you for this opportunity. I hope you have a great conference, but can I make a plea? It'd be great to have a conference that comes up with a very clear articulation of what would help. What would help and how, not how it could help, but how you could get it to go and start to bring benefits. So diolch am y cyfle I siarad heddiw. Thank you for this opportunity. I hope you have a brilliant conference. I see loads of interesting things, and I wish you all well. Thank you very much.
To practical action. So really grateful for that. Okay, so on with our first plenary session of the conference. So this is an interesting approach. So what we're hoping to do for the next half an hour is introduce 3 separate hit-style talks from colleagues I'll introduce in a second. Unfortunately, and partly understandably, given travel distances and weather, colleagues will be presenting online and can't be with us in the room today. So the first talk I'm going to introduce is going to be delivered by Trish Gray. Now, Trish is the head of programme for education, training and leadership development in NHS Scotland. And she's going to talk about the Rural Advanced Practice MSc. Trish is then going to be followed by Anna Turgey. Anna, I hope you pronounced your surname correctly there. Anna's a research fellow at the Centre for Rural Health Sciences in Scotland, who's going to be focusing on supporting GP recruitment and retention through postgraduate education. And then, depending on how time is flowing, either side of the 11 o'clock pause, we'll move to a discussion and a pre-recorded presentation from Ellen Griffiths from RHCW, who's going to be exploring with us how to bridge training and practice, and with a particular focus on the integrated GP fellowship in Wales. We may delay that until after the 11 o'clock pause, depending on time as it's progressing. So without further ado, I'd really like to welcome Trish Gray and great with colleagues in the room and show their appreciation. Thank you.
Thank you very much for the introduction there. I'll just share my slides. Okay, I'm hoping that everyone can see the slides now. Hello everyone. I am going to talk to you about the development of and delivery of the Rural Advanced Practice, otherwise known as the RAP MSc programme, and how it contributes to the sustainability of rural workforce and care within rural communities throughout Scotland. And I should say that I'm from NHS Education for Scotland, and I work within the National Centre for Remote and Rural Health and Care, and that was established in October 2023, and we are here to support the sustainability of primary and community care services in rural Scotland. So, okay. So if we look at the development of rural advanced practice education pathway, we had several inquiries at the time around this from rural boards in Scotland, from NHS Highland, Western Isles, Shetland and NHS Orkney. And that followed on work that we had completed in identifying a set of competencies for rural acute care GPs that went on to inform the basis of the Rural GP Fellowship programme. So the Rural Advanced Practice Education pathway was around supporting nurses and allied health professionals providing care throughout rural Scotland. And the requests and inquiries came in around supporting existing workforce in remote and rural practitioners, and really to enable them to continue to provide safe and effective care across the lifespan, so from 0 to 80 years plus. And really that was around, we wanted to make it more accessible. Quite often in rural communities, people have to travel to Central Belt to learn. So we wanted to make it online, accessible, affordable, and an inclusive education pathway that would meet the changing needs of the remote and rural healthcare workforce, and also the communities they serve. And the education pathway supports the GP contract, the Transforming Roles programme, paper 6 for nurses, and so ultimately supports multidisciplinary team integration and working, which is pivotal for rural areas throughout Scotland. So if we take a look at the challenges and why this education pathway might be needed, the dark green map there in Scotland it isn't entirely clear, but it highlights that it's remote areas in Scotland, and the light green areas are rural Scotland. So in terms of that, 98% of landmass Scotland, it's mostly rural, with just 17% of the population dispersed across those rural communities. And we've got lots of islands, 93 are inhabited, and that brings about unique challenges for healthcare. And there's ongoing inequalities in rural Scotland. They tend to experience them differently. There's economic barriers. There tends to be only one type of fuel for heating homes. They tend to be older homes. Public transport tends to be pretty poor. You really need a car, covering a wide geographic area that also contribute to healthcare inequalities. And often in rural areas, you can recruit, but it's difficult to retain staff quite often, particularly if they've came from an urban area. They get a better offer and they leave. And quite often it's that transitional period, transitioning in from urban areas into rural communities, that is really pivotal in supporting practitioners. And in rural Scotland, the population is ageing faster than anywhere else in Scotland. So with that brings about unique healthcare challenges. By 2041, 1 in 7 people will be over 75 years, and 1 in 3 will be over 65 years. And we have the highest rate of mortality of all the UK countries, and people in deprived areas in Scotland can live up to 24 years less than those in more affluent areas. So it's really pivotal to support rural practitioners. So just really a very quick resume of the consultation. That's what we undertook. It was national and international consultation. We had seminars, we had focus groups, and we launched what was called the Rural Advanced Practice Education Pathway and Capability Framework. And we thereafter had an Education Provider Day, and we commissioned the University of Highland and Islands to deliver the module content for the competencies that we had identified throughout the consultation process. And during putting together the competencies, we took into consideration the 7-year international partnership that looked at building investment recommendations and practical tools for the recruitment and retention of key remote and rural staff. And with that was around continuous CPD and the need for sustainable education pathways for rural practitioners, and Scotland was involved in that research partnership. So that was really around the rationale of putting together our competencies and the framework and the education pathway. So if we look at the pathway under the orange segment there, it highlights how a practitioner can come on to the Rural Advanced Practice course, and they really need to have undertaken non-medical prescribing and clinical assessment. They can then go on to year 2 of what we call the RAP MSc programme. They can exit with a PGE DIP, or they can go on and undertake the full master's programme. We haven't had any PhDs yet, but I understand there's ongoing discussions in that as well, but there is opportunity for that. So what does the Rural Advanced Practice capability consist of? It's an affordable and accessible inclusive education pathway at level 11 for advanced practitioners who need to use an additional rural set of skills to deliver safe and effective care in rural Scotland. It's got 7 capability statements organised into the NHS Education for Scotland 4 pillars of practice, which we refer to as clinical practice, facilitation protection of learning, leadership, and the importance of evidence-based research and development. And we have also put together a rural advanced practice learning needs assessment, which practitioners undertake to identify gaps in skills and knowledge. And that covers from 0 to 80 years plus. And one of the key things from focus group that was highlighted to us was the gaps across the lifespan, and in particular mental health and paediatrics as well. So here are the values and principles of living and working in remote, rural and island communities. That's a module that we put together to support the delivery of the Masters MSc, and that really looks at how people work, live and survive in providing care in rural communities. And I'll speak a bit more about that in the next slide. And again, key areas were care across the lifespan, and care effective, providing emergency care, prescribing across that age spectrum, and across the age spectrum for minor injury and minor ailments, and the importance of working collaboratively to provide evidence-based around that quality assurance for person-centred care, and also the importance of enabling self-management and well-being throughout the care journey for patients, and also the importance of leading, learning and ongoing quality improvement. So these are all embedded in the capability framework. So the values and principles of living and working in a remote and rural and island community looks at really what are the values needed to work within rural communities. It looks at the structures for strengthening personal and professional resilience. It looks at ethics and the need to interpret remote and rural national policy into the local needs of rural communities, and ensuring that empowering and resilience and well-being are ongoing. Strong leadership capabilities to ensure teams apply ethics at all aspects of the care journey. The final stages of the consultation for the capability framework and the pathway, just to highlight that they were shared with these various stakeholders and many others. One of the key feedbacks we received from focus groups was that supervision was very ad hoc for nurses and AHPs throughout Scotland when they were learning. It was really down to luck. It depended if you had a good or not so good experience. There was no standardised approach to it really, and so we put together an online rural advanced practice supervision, workplace supervision hub, and that's really around supporting learners and supervisors with learning resources to support supervision and excellence in rural advanced practice. It's an open site and the link is in the slide there for people who wish to click on and have a look at our supervision hub. The criteria for funding is that applicants are placed in primary and community care. Most of the applicants we've funded are in primary care services and GP practices. They have to have already undertaken and completed non-medical prescribing and clinical assessment, and they may exit with a PGE dip or go on and complete the full Masters programme. NES, NHS Education for Scotland, have funded over 30 practitioners to undertake the Rural Advanced Practice programme, and I'm delighted to say that graduation has taken place next week in Inverness, which I'm attending. And all practitioners have undertaken the course. They've all went on to complete a Masters programme. Some have said at the beginning diploma, but then confidence has built and they've said, no, I think I can do the Masters now, which is great. And we have a great ongoing partnership with the University of Highland and Islands for, we have yearly student induction and for delivery and evaluation of programme. And cohorts 2 and 3 are in process and we'll be funding next year as well. And just a quick resume of Rural Advanced Practice MSc evaluation. We have an evaluation team who have produced case studies highlighting the impact of the course, and they're available in the link in the slides. And we'll be reviewing the literature and linking in a realist evaluation framework with the RAP capability framework, just to ensure that evaluation has a robust approach and is adaptable and responsive to the realities of remote and rural and island contexts. And thereafter we'll be producing a structured report aligned to the research questions and the assessment criteria there. And that's our National Centre for Remote and Rural Health and Care website link. Thank you very much for listening.
Thank you, Claire. Trish, if it's okay, we'll run into the next presentation very quickly. I'll ask Anna to come in and deliver her talk, and then I'll ask you both to stay on the line if you like, because we might just invite some questions after 2 minutes. Yeah. Anna, welcome. I'm running straight to your discussion. I'm mindful of a little bit of personal time, and then we'll take questions after the break.
Thank you very much. Just share my slides. Well, it's not. Can you see that all right? Is it the center mode or? Okay, I'll presume it's fine then. Okay, thank you. Great. Okay, so yes, good morning. My name is Anna Teria. I'm a research fellow at the University of the Highlands and Islands within the Centre for Rural Health Sciences. So I'll be sharing some findings from an evaluation we did of the RAP program that Trish just gave a really comprehensive overview of, and I think we can save some time on the slides because my initial slides are a briefer version of that overview. So as Trish said, this was the evaluation was commissioned by the National Centre for Remote and Rural Health and Care. And we conducted it. I should say that I've not been involved in the delivery of the program, so only the evaluation. So what we wanted to explore was how the program contributes to rural workforce recruitment and retention, service innovation, and professional identity amongst those taking the course. So background and rationale, we have been over. Trish made a much better job of summarizing that than I would have. But, you know, one of the key things obviously is giving professionals the opportunity to advance clinically without leaving their communities. And there's a lot of alignment with health equity and rural workforce sustainability policies in Scotland, such as transforming roles and remote and rural health frameworks. So what we were aiming to do was answer 3 core questions. Program impact service delivery, recruitment and retention. What are the experiences of the supervision hub and online portfolio? And third, how the educational experience influences confidence, identity and practice in rural contexts. So what we conducted was a qualitative formative evaluation approach. So that was designed to explore lived experience rather than measure statistical outcomes. So we conducted interviews and focus groups with students and key stakeholders, and we also analysed some of the module evaluation data. And we used thematic analysis to identify recurring patterns related to workforce sustainability, education, and supervision. Excuse me. So just a whistle-stop tour of the key findings, which is categorized in 3 different kind of themes. So the first one is around service delivery and design. So students consistently described how the course enhanced their understanding of rural health challenges, things like transport, finances, community infrastructure, and the kind of things that their patients are facing. They were applying their learning directly to practice, working on some redesign of triage systems, initiating anticipatory care planning, and sometimes even challenging existing processes. The improvement service module in particular was described by a few of the students as transformative. So that both gave students the skills and the confidence to innovate locally. So in terms of recruitment, retention, and professional identity, so it appears that the program supports recruitment and retention by allowing practitioners to pursue postgraduate education while still staying embedded in their communities. And students spoke of developing a stronger sense of legitimacy that the course helped them justify and articulate their roles as advanced practitioners to others. Many gained confidence to take on more kind of leadership responsibilities or to mentor their peers. However, organizational recognition hasn't always yet caught up. So some graduates reported that despite advanced competencies, their job titles and pay bands remained unchanged, with little perceived prospects of this changing at the end of the course or going forward. Third, we have supervision and digital infrastructure, which emerged as key challenges. People spoke about supervision quality varying regionally. So some students benefited from excellent support, whilst others had little. The requirement to maintain both a university portfolio and an NHS tourist portfolio caused confusion and duplication amongst the students. And poor connectivity compounded these issues, with students struggling to upload materials or access online tools during clinical shifts. So that created some frustration amongst some of the students we spoke to. Educational experience. So students really praised the course's flexibility and the real-world relevance of it, especially people who are balancing full-time work and family life alongside their studies as well. As we all know, the online mode of these types of courses could be isolating, and having the workload of clinical duties and study was quite challenging for some, depending on their circumstances. However, where peer networks did exist, they were really invaluable, and where they didn't, students described the experience as a bit lonely, even though they felt very supported by the teaching staff. Few asked for more academic writing support, particularly people who were returning to study after years in practice. So looking at existing literature around this, so our findings align with that literature showing that local and context-sensitive postgraduate education has the potential to enhance both recruitment and retention. The RAP course supports what Chris and colleagues describe as professional identity formation, which helps practitioners articulate who they are and what they contribute. And at the same time, it echoes what Humphreys calls structural invisibility, the phenomenon where rural practitioners' roles evolve faster than organizational recognition structures can adapt. Few policy implications for Scotland. Policymakers must address structural inequalities and digital capacity gaps, as we have already talked about this morning, to ensure that programs like this are equitably implemented. So that includes embedding rural advanced practice within the national frameworks that we mentioned at the start. There needs to be more collaboration between universities and NHS boards to kind of try and streamline supervision and digital portfolios to reduce duplication and improve access. And systematic evaluation of equity outcomes is essential. So tracking who participates, who benefits, and who remains excluded. So in short, the RAP program is already making a difference. It's building confidence, capability, and innovation among rural clinicians. But sustaining this momentum requires alignment across systems, from academic curricula to NHS structures, and from digital platforms to professional recognition frameworks. So just to conclude, I want to highlight key areas for future development drawn from our evaluation findings. So First, program design. As we said, there's a strong case for closer integration between academic content and clinical competencies. So looking at regular alignment mechanisms between UHI and NHS supervisors could ensure that the curriculum continues to reflect real-world practice. Using things like locally grounded case studies and reflective projects will keep the learning relevant and applied. Second, supervision and support. So supervisors are pivotal, but they need structured training, clear guidance, and digital support. Regional peer learning groups and well-being or academic writing workshops could reduce isolation and also strengthen engagement within the program. Third, digital infrastructure. So the current duplication between university and NHS tourist portfolios could hopefully be streamlined, ideally through interoperability or single sign-on. And for learners in low connectivity areas, platforms need offline or asynchronous options as well. Fourth, workforce alignment. So RAP graduates need clear career pathways and job recognition. And that would need some collaboration with NHS boards and HR departments to formalize advanced practice roles, titles, and pay scales in line with the transforming roles framework. And finally, evaluation. So longitudinal follow-up, which I believe is kind of in the works, to look at what the graduates' impact over the next 3 to 5 years would be really interesting. And just expanding future studies to include more supervisors and employers to understand how learning translates into service change. And comparative evaluations with other advanced practice programs, both in Scotland and internationally, could also help find best practice. So Tapale, I hope I wasn't too much over time, but I tried to get through as fast as I could.
And it can stay on the line. Time's approaching, or just past 11 AM. So if I can invite colleagues both in the room here in Belf and online to fall silent, where we'll observe 2 minutes silence in memory and honor of those who've given the ultimate sacrifice and lost their lives in service of this country, both home and abroad. Thank you. Diolch yn fawr, everyone. Thank you very much. Okay, before we move on and hear a pre-recorded message from Elin Griffiths, can I just check if anyone has any particular questions they wanted to pose or indeed reflections they wanted to pose to either Trish or Anna? Can't see anyone online. Okay. So thanks very much, Trish, and grateful for you sharing your reflections on some evidence-based successful initiatives in Scotland, and probably give us some food for thought here in terms of how we progress that agenda in Wales, which I guess is a nice segue then to the next talk, which we'll hear from Elin Griffiths. Elin is a GP and medical educator. She's based in Llandilo. She's the Associate Dean for GP training in Hywel Dda and is the Programme Director for the Welsh Integrated Care GP Fellowship. So, as I said, unfortunately, Elin can't be with us in person today, but she has kindly taken the time to record a talk which we can access now.
That I presented in the RHCGP conference a couple of weeks ago, and I've basically been supported by Hywel Dda Health Board, so big shout out to them. Also RHCW, who I work for as well for half of the week, Bevan Commission, and obviously the Royal College as well, which has been really supportive of this scheme. So I'll tell you a little bit about it. Now, it was initially developed as a scheme for 1 year that would help newly qualified GPs to transition from training into a post-CCT job, whether it was salaried or partnership. But also, this job isn't just about transition. It really tests whether we can retain our GPs, especially in the more rural parts of Wales, and whether we can deliver that specialist care closer to home. And how do we do that? So this scheme is really a framework or a skeleton that's been used over the last 2-3 years to match a couple of needs that have developed over the last few years that really help with not just care closer to home, but with our changing workforce as well. So in a nutshell, a GP fellow works for a year in this post. They do 4 sessions in general practice. They do 2 sessions in a second interest, and I'll go into that in a little bit. They have 2 sessions of self-directed learning with some tailored sessions with me once every month. And they're about everything from partnership, understanding how systems work, the NHS, leadership, project management, and all these other things that GP registrars at the moment don't have that much time to be able to gain enough knowledge and experience in, because they're really focused on getting through training and passing their exams. Now, some key features of why this scheme is different from, say, a regular salaried job. So this scheme gives protected time, so paid time for mentorship. So they have mentorship throughout the post. They get protected growth, so they are met with me and their mentor, and they get enough time really, and like a curriculum that helps them develop these other skills that we need to develop these leaders within primary care. So they develop skills around their own personal leadership style, quality improvement, how to develop services in the community. They've also been doing research and innovation as well. So they're linked up with partners that are relevant for those different areas. Then the other key feature of this is that the second interest area that they take up is really driven by the population need. So what the population and the local health board that they're working in tells us, we really need help with this area or that type of work. So each post is tailored to what that particular population need is. So it's very much based on the community and the services that community needs. And then the other key feature of this is that this role is a flexible role that really is very attractive to GP registrars and newly qualified GPs or first 5 GPs, because it's got protected time for development, mentoring, it's got a second interest. It really appeals to people who don't want to work 8 sessions in general practice, but they want to do 4 or 5 sessions and then develop a portfolio role. So otherwise, to do a portfolio role, you just have to try and find a job and make it up yourself. But this scheme offers that framework to allow the GP to develop that role within a protected environment. So it's very appealing. For example, we applied for one fellowship job about a month ago. We had 16 applicants. They were all bar 2 from Wales, but 16 applicants for one role. So it's very much in demand. So all the things I'm going to talk to you about is coming out from evaluation data that I've gathered over the last 2 to 3 years. And I can share that with you if anybody wants to. I'll give you my details at the end. And I've also presented in DMEC and the RHCW Conference, as I mentioned. So the whole point of this is, you know, what's the impact? What does it show? So the data that I've gathered shows that these GPs really feel a much better transition from training into practice. Many of them, if not majority, have stayed in Wales, stayed in the area. A lot of them have been offered and taken up jobs, salaried and partnership in the practices that they were placed in. They've developed a lot more confidence, developed much better professional identity. And then the other improvements and the benefits to the local population and the practice. So one practice were able to develop a DOAC clinic with the help of the fellow. They also developed an ADHD shared care clinic. I've got another fellow who's developing hypertension and cardiovascular clinics with research services in Hywel Dda. So it's really bringing a lot of service improvements, and they're really developing their leadership and their innovation skills through the work that they're doing. And throughout the time, they're giving me information about their activities, what they're doing, and so we're evidencing it as we're going along. Now, the challenges really is balancing this increasing workload that we're seeing in general practice, the increased demand, against the development of these types of new roles, because we've got a changing workforce. So a lot of newly qualified GPs want a real varied job. So it's balancing, making sure that we're sort of sustaining GMS work, and we're not taking people away from GMS work, but we're making sure that we're getting the most out of the GPs that we've got that are qualifying over the last few years. The other challenge is that some of the fellows would like to do it for more than a year. They feel that a year is quite short. They often do a certificate or a qualification, and some of these qualifications take more than a year to do. And then the other big challenge is equity, making sure that it's being developed throughout all of Wales. So this scheme is available for all health boards throughout Wales, but at the moment it's only Hywel Dda Health Board that are have been able to take up this offer. And it's down to money, it's down to finances. So the way it works is the fellow's salary is paid for 50% by the general practice they're based in, 25% by HCIW, and then 25% by the health board to cover that second interest area. We've had fellows working in dermatology, diabetes, emergency medicine, because those were areas that Hywel Dda needed support with. But the other health boards have found it very difficult to be able to earmark the money to support having a fellow on their patch. So that's something I'm constantly working on and trying to sort of meet up with lots of different people to see if they're able to support a fellow in their area. So just to conclude, we've got lots of data that shows that this really strengthens GP retention. These doctors are staying in the area 2-3 years on, they're still there. They're often coming off local GP training schemes. So having something to offer them when they come off the scheme that's attractive, that they want to do, rather than go further down the M4 or into England. They're really satisfied with the job. They feel it gives them a lot of resilience. They feel it gives them a lot of leadership skills, developing innovation within their own practice and their own area. And it's been a proven scheme that showed a lot of impact, especially around transforming care. And we all know a healthier Wales and what the aims of that is, but how do we move these services out closer to patients? How do we move services that are specialised so that there is equity across Wales, especially into those more rural areas? So this scheme is a way of developing GPs out in the community, still working in practice, but also developing second interests. So the next steps, ensuring that there's equity across all regions. I'm more than happy if anybody wants to contact me. My address now will be on the next slide. The exciting thing that I've got going on now is that we've got 4 new fellows coming on in South Pembrokeshire. So the GP cluster there, a cluster of 3 practices, have decided by going through the whole sort of business case application that they would like to have fellows working in their practices and also in SDEC. So the health board and secondary care have also bought into this. So they're going to be rotating through SDEC and doing frailty clinics, as well as supporting GMS work in South Pembrokeshire, which has a large percentage of elderly population. So that's really exciting. They're going to be really supporting those practices, as well as bringing a lot of frailty framework work into that population. There's also lots of other areas that are interested in having fellows, such as gender services, ADHD services, and health inequalities. So these are areas that seem to be emerging as areas of need, that need a clinical lead, as well as the whole infrastructure to support that service developing. And that's it. Thank you very, very much for listening to me. If anybody wants to contact me, my email address is on this final slide. I'm sure we can share out this PowerPoint presentation as well. If anybody wants to click on those links, they can find out a bit more information about the scheme. And thank you very much. I hope you all have a wonderful day.
So some interesting comparative examples from Scotland and Wales there, both showing some signs of success. So really good examples for colleagues to reflect on. As Ellen obviously can't be with us, what I'm going to suggest was she is with us tomorrow. So we've got a choice really. We can either take your question and post that to her, or we can deal with those particular questions for Ellen tomorrow. Yeah. So, a couple of questions from the floor, so we'll just take those down. Yeah.
Yeah. I'm Gynhadledd and I'm the Regional Director for Heist in Paris. And just for both presentations, and Trish, I don't know whether you're still there, I'm just giving you a bit of a heads up, but if she is, both presentations very much focused on the need for collaboration. Sorry, thank you. So the need for collaboration and issues around cross-border and cross-boundary. And from my perspective, the question really is around how it's about the patient and not the boundary. And so the last presentation, which was extremely interesting, I'd be very interested in, maybe I'll speak to Ellen tomorrow, about how that's being rolled out in other parts of Wales, particularly Powys, which is where I represent patients. Given that we don't have a university in Powys, that'd be really interesting to know that. And then, I don't know, is Tricia still there?
Trish, are you with us?
That's fine. We can my question to Trish was around the remote rural and islands area. I've just done a quick Google, and there are 4 health boards that cover that particular patch. And so my question really was going to be, Trish, maybe we can take it forward, Anna, if that's okay, around whether that particular framework was being delivered individually in each of the 4 areas, or whether it was a collaborative approach around amongst the 4 health boards. And if it was, how did that work and what lessons were learned? Because collaboration around cross-border and cross-boundary has to be the way forward.
Okay. Katie, thank you for that. So what we'll do, we'll note that question around consistency across those 4 health board areas and pose that to Trish and finish the response. Anna, can I check, are you with us still, or have you left?
I'm still here.
So, Anna, do you want to reflect on Katie's first question, collaboration, and just that focus on the patient and ensuring that the patient isn't disadvantaged, if you like, in terms of some of those cross-boundary issues that inevitably raise when looking at those models across a wider geographical area?
Yeah, probably not as well as Trish could, but I think collaboration is always a challenge, and what became very apparent in the evaluation was that there were differences in how collaboratively people within health boards worked, and certainly across health boards is a challenge, and that could lead to potentially, patients being disadvantaged by lack of services and lack of services speaking to each other. So I think it's really important to develop those networks, and there seems to be a lot of duplication and best practice that isn't always shared. So I think that's important to develop, but I'm not sure I have the answer as to how to overcome that.
As well to finish your response. Yeah.
I was wondering, with their data collection, have they actually received and gathered the information in Wales, particularly, obviously, and in Powys, of all the GP practices that actually have a fellowship ongoing, or would be putting on forward in the future? And actually, is there a facility to ensure that actually that is equitable for the whole of Wales, and there is someone who makes sure that there is a fellow in every GP practice?
Okay, thank you, Jackie. So just for colleagues online, there's a question there around equity around practices across Wales and not certain particular areas. Jackie, as you're aware, Ellen's not with us, so probably unfair for me to pose that question to colleagues from Scotland. But what we will do, you've got two options really. We'll furnish that question to Ellen to elicit a response. If you are here tomorrow, then obviously there's the opportunity to share that question with her.
Thanks.
Okay, so we'll do that on your behalf and then we'll finish your response to yourself. Okay, thank you. Right, I'm mindful we're a little bit behind time, so thank you for your indulgence earlier on. I'm now going to welcome Dr. Adam Mackridge to the stage. Adam is the strategic lead for community pharmacy in Betsy Cadwallader Health Board area. He's a pharmacist. He's an academic, he's an experienced healthcare leader, and he's going to talk to us around opportunities to improve access to medicines in rural and isolated localities. Adam, welcome.
Hello, everybody. Yes, I want to talk to you about the remedy study that we've been running in the Betsy area, and I'm going to talk a little bit about my experience with. I wear 2 hats with this. I'm leading the implementation of the intervention within the health board, but I'm also part of the research team as I work at Bangor University part-time as well. So we've got there'll be quite a few pictures of nice countryside in this as well to just highlight the rurality of everything. But we've got a problem, haven't we, around access to medicines in many areas. Over 70% of our out-of-hours consultations now are managed remotely. But in many of those cases, patients are going to need medication to complete their care journey, and patient access to medicines is going to be variable. If you live in a densely populated area, there is likely to be a base or a pharmacy open or something like that where you'll be able to get access to medication. If you live in a low population density area, rural areas, isolated communities, that's much less likely, and you're more likely to fall through the gaps there. Community pharmacy availability across the UK has reduced over the last decade or so. We do still have many pharmacies that open Sundays and Saturdays and evenings, but nowhere near as many as we used to have. And in our rural communities, they've been much more affected by that than perhaps the more urban areas. Obviously, if you live in a rural area, access to some form of transport is quite critical to access most services. But public transport is often not running late at night. It's often not running on weekends, bank holidays to the same level. Therefore, rural areas get hit multiple times over with this through reduced availability and reduced access to transport. So I'm going to give you a patient story. It's fictionalized to protect patient confidentiality, but we'll talk about Gwen. So Gwen's a farmer in South Meirionydd. She's got well-controlled Addison's disease, but she's picked up a tummy bug. It's been going around the family. She's been affected by it. She's throwing up all the time. So she called 111. She speaks to a clinician over the phone who correctly is able to work out what's going on, recognizing that she's not keeping down her medication for her Addison's, and a major problem for her is controlling that Addison's. Therefore, some anti-sickness medications needed. So they prescribe the medication, but then she's faced with a 2-hour round trip to the nearest location she can get that medication. She's not well enough to travel. There's a couple of other family members that aren't well enough to travel. And that means everybody else is all hands on deck trying to run the farm. So nobody can go to the base to collect that medication. So Gwen just has to accept the situation she's in. There's no alternative for her, and goes to bed. In the morning, she can't be woken by the family. So it's a 999, ambulance to hospital, and a 5-day admission due to a complication with her Addison's. That's an avoidable situation. All we needed was some anti-sickness medication, which could easily have been given to her in another setting, but in this setting, in these circumstances, she was unable to access that. That's used resources up that could have been used by other people and having knock-on effects in the system. And we've had a patient who's experienced a serious medical event as a consequence of that. So that's the problem we're dealing with. But just to say, that's not a new problem. As early as 1939, one of the doctors working in the Australian Flying Doctor Service highlighted this issue for them, that telehealth has a limited value. They were talking about using radios in those days. It wasn't even phone calls. But unless we can get that medicine to the patient, we are always going to be restricted with how much we can do at a distance to support patients. So this problem exists in numbers of various communities around the world. And we have a few solutions to them so far. One that's commonly used in Wales is supplying medicines through an out-of-hours base. So where we've got a GP or other clinicians working out of a location running out-of-hours services, they will hold a small stock of medicines there. The patients will often have to drive to that location or somehow get there to collect the medication, and the clinician will dispense it from stock. But for some patients, that can still be a very long journey. There's often delays as a consequence of the fact that they've got to make the journey or they can't make the journey, and that leads to them having to wait either for a family member to take them when they're available, or friend, or for a local service to open. And it also adds pressure to the out-of-hours services themselves, because we're taking a clinician's time up to supply the medication as well. In other areas, such as Australia, the Falkland Islands, they use medicines chests. So these are chests full of medicines. You can see a picture of one there, that are held by somebody locally in the community who's volunteered. And then they're issued on the instructions of a doctor or another appropriate clinician. So following the consultation, that medicines chest holder will be contacted and asked to supply a medicine. And they use things like alpha, beta, delta, and there'll be a huge letter on the box to reduce the risk of picking errors, because these are not healthcare professionals. They might be a farmer or somebody running a community shop in an isolated community. And sometimes they have other things in them, like pulse oximeters or wound dressings to support more local support for the patient. They again have their challenges in terms of patient confidentiality. We need a person to be available. We need a volunteer, and then we're trying to maintain this chest of medicines, and there's audit trails and things like that. Slight variation in Pakistan. Healthcare support workers will hold the medicines chest, so that's a little bit of a different approach, where they actually will take things like OBS from the patient as well, which supports the clinician to provide remote care. But that's in a different context in terms of workforce availability and costs associated with workforce. And also the availability of healthcare is different, obviously, to the UK. But that's just to give you an example of something else that's happening elsewhere. We've got some low-tech solutions we use in the UK. Exacerbations of chronic illness can be managed through rescue packs. And things like steroids or antibiotics that are held by somebody with COPD, for example. So they mean that rapid treatment can be given by a family member or the patient themselves. But obviously, we have issues with with rescue packs sometimes not being held by the patient when they would have liked them to have been, or being used inappropriately. And we've also got just-in-case medication, just-in-case packs, anticipatory medicine. This requires a lot of planning, a lot of support, and it is used effectively in many areas, particularly in end-of-life care, but still has its downsides in terms of making sure that medicines are used appropriately. And then drones. This has been talked about by lots of people over the last few years. Professor Nigel Rees has been doing some work in WAST around delivery of defibrillator machines. And I've been involved in the periphery of some conversations, others are leading it, Nigel particularly, around potential to deliver medicines through drones as well. And there's some tests happening in America as well around the use of drones. So those are some of the things that are happening at the moment. But what I'm going to talk to you about particularly is the possible future. And I say the possible future because we are looking at this as a first time in the world it's been tried. We're trying to develop something, evaluate it, and improve it, and see if we can make it work effectively. So this machine that you can see here on the photo outside of pharmacy is a PharmaSelf machine, and they're used to put medicines that have been dispensed by the pharmacy in there. The patient gets a text message and they go and collect it, and they can use that 24 hours a day. That hardware is well established, been used in the UK for a number of years now, as well as a number of other countries. But what we've done is we've worked with the manufacturer of the Remedy machine, of the PharmaSelf machine, to develop the Remedy machine. It's the same hardware, but we've asked them to develop the software, and we work with them to do that. And this now allows a clinician who's completed the remote consultation to access the machine, which is preloaded with medicines we've identified as being the sorts of things we would want to start urgently for a patient. And this issues a PIN code to the patient, who then goes to the machine, puts their PIN in, and it opens. This particular model has 5 doors on the side there. A light will light up on one of the doors. It's a bit like a vending machine inside, a little carousel. The carousel turns around, the door flashes, you open the door, and there's the medicine you need. So hopefully this video will work. Sorry, we just bear with me, a little bit of a technical change here. There we are. So you should be able to see there. This is one of my pharmacy colleagues' son, who's just had some surgery for his cruciate ligament, which is why he's on crutches. But he's demonstrating the use of the machine. So he's just typing in the PIN code. The carousel takes a few minutes to rotate round to display the correct medicine. Can't see it from this angle, but there's some lights on the right-hand side of each of those doors. We're looking at the operational data to see how it's being used, when it's being used, when it's not being used as well. And we're about to start organising some community meetings in Diwrnod area to look at how the local community have responded to the machine, or their interests and what their concerns are. And I mentioned Holyhead earlier. I'm also in the process of trying to get the funding to enable us to install a second machine in Holyhead. Although it's not as far to drive as Gynhadledd is from Bangor, it's still just as challenging from a public transport point of view if you haven't got access to a car, and can still be just as problematic in terms of tourist population needing support, and Bangor being a good half an hour away for many people at that side of the island. Plus, we also have some interesting challenges with the bridge over the Menai Straits from time to time. So that's the experience we're having in North Wales at the moment. I'm happy to take any questions if anybody has any.
Take one question.
And that's fantastic news. I was highlighting that is there a possibility of using blood bikers who they are volunteer service, but they are very good at getting things to places. Obviously, it has to be individuals who carry blood around the country. And also, what about advanced practitioners in local areas as well? I love the machines, I think they're wonderful. Can I just ask about controlled drugs? We actually had our co-op in Town Bath was actually set upon, and the outside back was stolen. The whole of the banking system was stolen. It's deep down the co-op. So, I'm looking at controlled drugs. What's the situation with that, please?
So, just to repeat the questions, I'll just, I think there was a couple in there. So we'll start on the controlled drugs. So questions about, controlled drugs. There are no controlled drugs in this machine at the moment. That's because whilst we looked at the regulatory issues from the human medicines regulations, the misuse of drugs regulations are a whole other kettle of fish. We haven't gone there yet. We need to work out whether this is an effective solution. We know the system works, and the focus of the research is, does it work in the real world? So we have used the machine. I think there's a handful of patients have actually used the machine in the real world context as well as user testing. But the study, which runs to April 2027, is about, can we embed it within practice? As part of that, we're looking at what might we want to put in the machine in the future. End-of-life care medicines would be a key controlled drugs area we might want to focus on. But that's what I would very much class phase 2. And there would need to be more focus on security and that side of things. Although these machines are used in community pharmacies, and there's been one example of vandalism over the last decade, but no security issues at all. So they are very secure machines, I should say. And there was another component to your question about blood bikes as well. Yes. So yes, we do use blood bikes in the out-of-hours service from time to time. I've used them myself to send medication to a patient. It is brilliant in those circumstances where there really are no alternatives, but it's fairly limited in terms of how many bikers are available and the coordination and organisation of it, and mobilising somebody. That I think somebody had to drive 45 minutes to where I was to get the medication, to then drive to the patient, and then drive home, and it was quite a significant activity for that particular blood bikes person. In South Wales, the 111 Clinical Hub have also done something similar with the St John Ambulance, using volunteers to try and support patients in that way. There is a place for it. We use our drivers from our out-of-hours services as another way, but it's very resource intensive and relies on, if your driver's already doing something, then we need to wait for them to come back before, and you could quickly exhaust the resource for 2 or 3 patients, and then we're a bit stuck. Yeah, and things like the medicines chest offer other options, but the beauty of the machine is we've got a clinician there at 3 a.m. You can go to that machine at 3 a.m. If we're using an advanced practitioner, we won't have those working 24 hours a day in every location. So there are opportunities. There are also some legal challenges with medicines chests in the UK.
Sorry. If you don't mind, I'm going to need to move us on because we're a little bit behind time, and we're not going to lose the thread of your questions.
Can I make one observation?
By all means, yes. Yeah.
It's about cross-border and where the 100 patients could go to Gynhadledd. So I just put that there
as a recurrent theme there in terms of thinking for us in terms of when we're planning some of these initiatives, is just making sure that this is seconded from the needs of the patient. Yeah, and I'm really grateful. Grateful for Colin will show their appreciation for having this conversation. I was just reflecting back on Dr. Chris Jones's challenge to us at the start of the day around translating ambition and concept into practical action. Certainly, I think what you described there is a really good example of that. So thank you for sharing that. So I'm really grateful. Okay. We now need to move to our breakout sessions. So as you've noted, we're a little bit behind time. So as you've seen from the information that's been shared with you already, you need to choose which of the 3 talks you wish to attend in this first breakout session. There's one in this room for calling delegates in person here in Belgium, and there's one either on the ground floor or the first floor of the international building across the way. You've just got a quick opportunity to grab a camera and take it with you across to the international building if you wish to attend one of the talks in that building. Colleagues online, you just need to follow the guidance you've got there in clicking the link for the relevant breakout group that you wish to attend related to the talk that you are most interested in. Yeah. So I'll give you a couple of minutes just to grab a quick cuppa or have a quick stretch, find the right location for the talk you're interested in, and then we'll proceed with the breakout presentations. Thank you. Okay, everyone, I'm inviting you to fall back to your seats and make sure you've found your way to the location that best suits your interest for the breakout session. So, as I mentioned just before the break, you're now going to commence our breakout sessions. We have 3 to work through. The first will be pre-lunch, then we'll break for lunch, and then we'll follow on with the second and third breakout sessions. So, without further ado, here in the Montgomery Pavilion, I'm really pleased to introduce to you Professor Johnson Pinker from, in a little while, Johnson from the Eureka Foundation. If I can ask colleagues to take this, if possible, so we can proceed. Just make sure we're running to time. After colleagues have spoken in this room, we will break for lunch, yeah, and then after lunch we go automatically to the next relevant location for your breakout session. Please show your appreciation for Joss. Thank you.
Good morning, nearly lunchtime. So I'm Joyce Kenkry, and I'm Emeritus Professor of Primary Care, but also co-chair Scientific Board for Eureka. And Eureka is the Rural Isolated Practitioners Association. And it's really looking towards working together in collaboration to address the health and wellbeing needs of the rural population and professional needs of those serving those in Europe. And Eureka members provide information for the development of European Union and WHO policy making and initiatives. So in that, the Wittenberg Statement at the 14th Rural Forum this year draws inspiration from the historical Reformation as a metaphor for structural transformation, just as the 16th century movement challenged centralisation, authority, democratised access to knowledge and empowered local actors. This statement advocates for the revision of healthcare policy and wider systems to focus on health and well-being of rural populations across Europe. The statement is underpinned by the conviction that equitable healthcare cannot be achieved without recognising the distinct needs, strengths and contributions of rural communities. The following core insights derived from cross-national dialogue among rural health professionals, researchers and system thinkers articulate a contemporary vision for reform. So the first of these is decentralised and local authority. Current healthcare governance structures remain overly centralised, often failing to reflect the operative realities of rural practice. There is a pressing need for greater regional autonomy, flexible funding mechanisms, pressing need for greater regional autonomy, flexible funding mechanisms and localised decision-making that empowers rural communities and healthcare professionals as co-architects of care delivery rather than policy end users. The next issue was translation of knowledge into practice. Medical education and clinical guidelines frequently lack relevance to rural contexts. Reform efforts must prioritise the translation of evidence into rural-proofed, context-sensitive and actionable tools and protocols. Digital health literacy initiatives should support rural practitioners and communities in navigating and applying complex medical knowledge effectively. The next issue, so I missed one. So empowerment of rural frontline healthcare professionals and community-centred practice. Rural practitioners must be recognised for not merely for implementers of practice, but as active drivers of systematic change. Grassroots innovations, particularly those involving community needs assessments and engagement, digital platforms and collaborative networks, should be acknowledged, supported, publicly funded and scaled. The potential role of a range of healthcare professionals in primary care should be assessed, developed to support and supplement the work of rural family doctors in the interest of future community-based interprofessional primary care. The next issue that was agreed on was funding opportunities should be made available for rural research, as strengthening research capacity at the rural level is essential to ensuring that policy is involved by lived experiences, bringing together knowledge, needs, and community assets that can inform and shape future research and address and inform future practice. Rural populations participation must be actively considered and involved in the design and delivery of healthcare research and clinical trials. Rural recruitment and participation should be monitored by national research bodies, and researchers should be able to develop their careers within rural settings. Universities, education institutions and organisations must ensure that staff from rural areas can take research positions through providing flexible working opportunities, access to financial support, accommodation and travel costs. The next issue that was agreed was strategic use of technology. Contemporary digital tools must not replace rural-based service provision from local healthcare professionals and community services. Smart devices, telemedicine, artificial intelligence and open health data have transformative potential. However, the deployment must be contextual and appropriate and equity-driven. Investment in technological infrastructure and training in rural communities is necessary to ensure these tools serve as instruments of inclusion rather than further marginalisation. When services are digitised, monitoring of impact and outcomes must be undertaken to ensure rural communities are not disadvantaged. The next issue was rural practice must be recognised for its adaptability, generalist expertise, resilience and potential to pioneer integrated community health-based models. Prevailing models of healthcare excellence often reinforce urbanised centric norms and must be challenged. The next issue was the persistence of rural health disparities constitutes a systematic injustice. Reform must be independent underpinned by moral clarity and explicit commitment to social equity. This statement to a modern set of reinforces the modern state of Lucid 95 thesis must serve as a unifying framework to mobilise policymakers, practitioners and the public. The next issue, agreed. It's not moving. Is sustained commitment to rural health reform. Rural actors must deep-rooted connections, knowledge and expertise, but often struggle to navigate wider organisational structures. Bureaucratic and organisational structures should actively engage and support the rural voice in redesigning and delivering sustainable services in rural areas. The next issue, although we can't use it, is legally orientated reform. A successful rural reformation will lay the groundwork for lasting structural change. Health systems are place sensitive, a workforce trained to and for rural realities and research agendas shaped by and responsive to rural experience. The next issue agreed was building alliances around shared vision values. The future of rural healthcare depends on the strength of coalitions. Shared values such as equity, sustainability and solidarity must guide cross-sector collaboration. Strategic alliances with patients, policymakers and academic institutions and technology developers are essential to the translation of a vision into lasting impact. The next issue is One Health. The One Health approach to rural communities is essential for environmental sustainability and the well-being of future generations, empowering rural communities and reinforcing the strategic capacity of the agricultural, forestry and other economic sectors will underpin the stability of our countries. In the face of growing geopolitical challenges, sustained investment in Europe's rural medicine and comprehensive rural healthcare reforms are vital. So finally, the Wittenberg Statement of 2025 is going to be taken forward and accepted by all delegates of the 14th Rural Health Forum, and it's both a call for action and a roadmap for transformation. It affirms that rural communities do not seek exceptional treatment, but demand equitable recognition, structural investment and sustained participation and partnership. The statement invites all stakeholders to participate in shaping a healthcare future that is inclusive, evidence-based and responsive to the voices of those who live in rural communities and who serve rural communities are central to the health of the continent. I don't know whether the next slide is there. So we're really trying to work across Europe on addressing these issues and thinking how we can actually collaborate and go forward. And after the same meeting, we set the top 5 priorities, but these are the top 5. And it's thinking about artificial intelligence to complement and promote equity, the use of technology to enhance community continuity of care, about enhancing diagnostic positives through near patient diagnostics, multidisciplinary teams, achieving needs-based workforce, and awareness and perception of social prescribing. So I know it was a bit of a long haul, but it was something that was developed across European general practitioners and the multidisciplinary teams to say how can we make a base to set a platform for the future. So thank you. Just thought I'd make the statements.
Just apologies for the slight glitch with the slides during the presentation, but that could be tracked.
That's okay.
Yeah. Okay, I'm now going to welcome Dr. Veronica Razik. Veronica is a GP in the Neath Valley. She's a founder of campus, and she's come to talk about her perspective on equity in healthcare.
Thank you very much. So yes, my name is Veronica, and I'll be talking a little bit more about rural health equity and the gaps that we have in Wales and what we might be able to do to try and bridge those gaps. So I think it's useful to perhaps define what we keep mentioning here. So health equity, what is health equity? So health equity, according to the WHO, is the absence of unfair and avoidable differences between different population groups. When we talk about health equity, often in the medical community, we're talking about the social determinants of health. So we're thinking about the environment within which people are born, grow, live, work, and age. But when we say wider determinants of health, often we're referring to other elements of what could also be classed social determinants of health, but sometimes they will be called environmental determinants of health. So these can be chemicals in the environment, air pollution, things like that. There are commercial determinants of health. So these refer to effects from corporate activities. So if we think big oil, big food, that kind of thing. And then we have political determinants of health. So these are things like policies and laws that form the structural environment within which all of this is going on. So the WHO and OECD have also been working on the rural health equity question for some time now. And this is a slide that they've developed highlighting the global imperative of rural health equity. And globally, we have over 2 billion people that are living in rural and remote areas that often lack access to adequate healthcare. So the two elements, I'm just going to very briefly reflect on this, that we're looking at is how do we strengthen rural health systems? And the second side is how do we address all of those determinants of health that I mentioned earlier? So collaborative working, which has also been mentioned multiple times today. When we're talking about Wales, so where are we in Wales in regards to health equity? So we know that 1 in 4 people in Wales live in relative income poverty, and this goes up to 1 in 3 when we're talking about children. We have an aging population in Wales, and there is a higher proportion of older people in more rural and coastal communities. So places like Powys or Anglesey have a higher percentage than the rest of Wales. We also have people with disabilities who often aren't mentioned enough, but this also accounts for 1 in 5 people, and of those, many of them will have their daily activities affected by those disabilities. And when we're talking about disabilities, often people are thinking someone in a wheelchair, but it doesn't have to be. It can be things like hearing loss, which tends to come on in older age, or just lower mobility as people get older. And I think it's important to mention we have about 5% of children under 5, and this is a group that I think we should be thinking about more when we're thinking about social determinants of health and longer-term prevention. And then we also have about 6% of people who belong to Black, Asian, and minority ethnic groups who often face greater inequity. So what are the drivers for rural health inequity? So there was work done by the NHS Strategy Unit in 2023 that highlighted these elements here. So things like the fact that health and care is dispersed, it costs more to provide care in those contexts. There's issues with funding and investment in rural and remote areas. We've got the demography issues, so aging population. We have issues with digital connectivity, transport connectivity, housing, fuel poverty are a factor, isolation, deprivation in certain rural areas, and of course workforce issues in the NHS and social care, but it doesn't just affect NHS and social care. So there's workforce issues in education and other sectors as well. And of course, more global challenges such as climate change. So I've decided to show you this slide just to highlight how Wales measures the social gradient and how it looks at social determinants of health. So it looks at 8 domains. I pulled out 2 here. So on the left, you see the health domain. On the right, you see access to services domain. Now, if we were to just take the health domain, we would say, so to highlight also, the darker the blue, the more deprived the area, just so it makes sense. So if we look at the health domain, it looks like rural Wales is very healthy compared to the urban areas and the valleys, okay? But when we look at the services domain, and when we think about what is it that the services domain covers, so this is how far is your GP? Where is your pharmacy? Do you have a school in your community? Are you able to go to sports facilities? So those are all things that affect health and well-being. It's a drastically different picture. And I would argue that the Welsh Index of Multiple Deprivation does not adequately measure what is going on in rural communities. And this has been confirmed multiple times. There's been work done very recently. So I would encourage you all to have a look at something that's called the Pretty Poverty Report, which came out recently from Plymouth University, I believe. They looked at what is happening in Cornwall. And they identified also that the index of multiple deprivation in England is not adequately identifying rural deprivation. Now mine is not working.
So okay, catch up for you.
I have to remember what my next was. I think my next slide will have an image of the Welsh well-being of future generations act for good reason. So I'm reflecting here a little bit on what we can do from the policy space as well. And Wales has very good progressive legislation that has come through that we all can use as a policy lever or a tool for change that we want to see. So the Act calls for kind of forward thinking about what decisions today will mean for generations tomorrow. And this is a very good thing to keep in mind. Thank you. As we are thinking about how can we address the gaps that we're seeing. So through my work, I've seen kind of three major disconnects when we're looking at what's going on the front line with clinicians or community leaders and what's happening in the policy space. So these disconnects are the communication gap, the policy language barrier, and the consequence of urban-centric approaches. So firstly, the communication gap is mostly around rural voices not being heard in places where the decisions are being made. And often decision makers not really seeking out those views. So even though we know that rural clinicians and community members often are finding solutions to the challenges that they're facing, that is not being supported and those views aren't really being sought. So that's one of the challenges. The second is policy language barrier, which is just a way to say that often policymakers will talk in metrics and they have their own special language that they use and targets, and it doesn't always make sense to people who aren't in that space. And similarly, when communities are doing really good work, they don't always have the capacity, the skills, or the ability to know how to translate that work into something that policymakers would understand, so to meet those metrics and targets that they're looking for. And finally, both of those together lead to this kind of consequence of urban-centric approaches. So often decisions are being made by people who have never had experience of living or working in a rural context, and so policies are not always very effective in our rural context. And on the other side here, I've suggested possible things we could do to try and address that. So we do need better rural data for decision making, but at the same time, we need to use the data that we have better. So sometimes it's about collating all of the work that's already been done and presenting it in a different way. The second is clear communication. So developing better communication channels, both between communities, policymakers, between clinicians, researchers, and making those communication channels stronger. And finally, rural proofing, so applying a rural lens to the policies that are being developed. So over the past 18 months or so, I have been holding space for the Rural Health Equity Chat community. So this is really an online community that comes together about once a month and talks about different rural health challenges. So we've had topics from creative health, aging in rural areas, children and young people in rural areas, and it brings together people from all sectors, so local councils, community organizations, academia, health and social care. So through this, I've been listening, And what was coming up was that what we really need in the UK is some kind of rural health equity strategy. Because at the moment, what's happening is we have persistent rural health inequity, but we have very non-coordinated activity around it. And everyone tends to look at their silo. So recruitment, retention of healthcare workers, transport maybe gets looked at on its own, but there's no kind of cross-sector collaboration, which is something that we really do need to see. So this is something that I decided to very ambitiously attempt to take forward. And initially, I tried to see who would be interested to support this and brought together a steering group of which we have between 12 and 15 people that have voluntarily come forward. And I tried to put together an initial proposal from what I was hearing. So the initial proposal was to try and focus on 4 broad areas. So those areas are aging population, mental well-being, connectivity, looking at both transport and digital things, and then funding, structure and investment, because these were the things that kept coming up over and over again. And the other important part of this was to take a life course approach, so that we wouldn't focus just on the medical side of things, but what do actually people need for their well-being in the community. And with that, for example, if we look at aging population, we wouldn't look at just what do elderly people need health and social care wise, but what does an aging population mean for children, mean for schools, mean for adults who need to provide care to their parents. So that kind of approach. And what we would ideally want from this strategy was that it is flexible and practical. So flexible so that it can be applied in the different rural contexts. Very ambitious. So some of the ideas that then came through from the steering committee were these 4. So should we be looking at a rural well-being economy type strategy where we try and integrate work that is already being done in the political space around well-being economy and try and say, well, this is what it would look like in a rural setting? The second big point was around scoping existing evidence. And as I said, not doubling up on our work, but making use of the evidence that already exists and using our networks to find out what's happening. So like today with the Remedy and other projects that are going on. Third were implementation labs. So to have implementation labs in each of the 4 UK countries to account for the differences in legislation and things like this. But also to make sure that we're creating with communities and having communities lead this process, because one of the main things of this strategy was we didn't want another top-down strategy. We wanted to create this from the bottom and then feed that information up, which is challenging. I agree. And then the fourth was about that policy engagement and how we would go about sharing our messages with relevant policy actors, so how we could connect with MPs, councillors, or whoever else would be an ally in this process. Please. Next slide is really one where I have a QR code for you, because the idea was that I would hand it back to you and ask, what do you think about this? Is this something that you and your organizations would find useful? Are there reports, projects, research, things that you have been doing that you could share that would be helpful, that could be used as case studies, or that you've done research already, you've made the evidence, but you haven't been able to get that evidence to a place that it can be seen by someone who has a decision-making role? And is there something we're completely missing? Is there something that's coming up for you that we haven't touched upon? So we're interested in getting your feedback. And I would be very happy to chat with anyone who would like to at the lunchtime or during the day. But yeah, deal, and let us get going.
Thank you, Veronica. I'm just going to suggest that you are going for a few minutes of colleagues to maybe we could put that back on the screen. Okay, that's it. Okay, so We've now arrived at the lunch break, so I'd really like to thank all of the contributors and presenters from this morning's session. Thank you all. Just for clarity then, in terms of our logistics as we move into the afternoon session. So immediately following lunch, which will end at 1 p.m. We'll then move into the second breakout session. So again, for colleagues here in North Wales and those online, please make sure you select the right location for the talk that you're interested in. So the breakout session 2 will start at 1 p.m. and then that will run through to 1:30, where you will automatically then run through into the third breakout session. And again, make sure you follow the directions either physically or digitally for your preferred session. Just a note on the third breakout session, I should have mentioned this earlier on. Unfortunately, the Pembrokeshire Early Years team have been unable to join us today, so they've had to withdraw from a presentation at the conference today. So for the breakout session 3, your choices are restricted to 2 options, I'm afraid. So just note that when we get to that point. And then for 2 p.m, we will all regather here in the Montgomery Pavilion, where we'll move into plenary session 3. So thanks for your attention, your questions and your contributions this morning's session. Please enjoy lunch. Please enjoy an opportunity to stretch your legs, etc. I'm mindful, I did mention this morning that really keen to engage your views in your reflections on the various poster presentations. So don't forget about that and the scoring sheets that you've got within your presentation packs. And of course, still see Sean sitting over there in the corner of the room here in North Wales. So if you want to have a conversation about CPR or see a demo or have any conversation about that aspect of the right approach, then Sean's a lady over in the corner. Thank you all. Enjoy your lunch break. Okay, everyone, if I can call everybody to regather. So we've now arrived at the breakout session 2. Yeah. So as a quick reminder, please select the correct location for the relevant talk you wish to attend. So in here, in the pavilion, we have a discussion around the role of the NHS Wales app in rural communities. Over in the international ground floor area, we've got a talk around cross-sector multi-agency preventative care delivery. And then up on the first floor in the International Centre, we've got a discussion around the role of drama and movement workshops, supporting people with communication difficulties. So hopefully you found yourselves into the correct location, and that leaves me therefore to welcome both Joanna Dundon, the National Digital Lead for the NHS Wales app, and colleague Gareth Williams, the Digital Inclusion Manager for RHCW. Joanna,
thank you very much. Thank you. Thank you, Dylan. We need to stand in. Yeah, sure. Okay, sorry, Dennis is just coming around with mental codes, so we thought it would be useful for all to share. So, thank you very much for inviting us to talk today. I'm Jo Dundon, I'm National Digital Lead Public Engagement, Digital Health and Care Wales, and Engagement Lead for Digital Services with Patients in the Public programme, looking at rolling out the NHS Wales app. Today with me is Delyth. I'll let her introduce herself.
Hi, I'm Delyth, the Digital Inclusion Manager for RHCW.
Okay.
So just as a bit of a welcome, Croeso, if you want to scan the QR code, we're just considering now, just while we move through the session, what kind of roles do we play within our different aspects of our lives? So this could be what you do for work, this could be who you are as a person. So you feel free to just add things to that as we go through. It's just a bit of interactivity. As we just start to introduce this session.
Is everyone? Are we frozen on it?
No, no, it's okay.
Am I pressing the right button?
We froze it away.
Frozen already. Okay. There we go.
Awesome. So we've got some aims for today's session. We're going to be giving you a bit of an update on the NHS Wales app, and just Joe's going to be leading you through that. We're then just going to have a quick look at what is the importance of rural digital healthcare, and finally then we're just going to have a look at some co-creation of solutions, so building on some of the things that were said this morning, just thinking about how can we work together to fix some of these tricky issues.
Thank you. Thank you very much, Dennis. So I don't know how many of you put hands up, how many of you have heard of the NHS Wales app, and how many of you have downloaded it and are using it. So there's quite a few. That's really good. Makes my job a little bit easier now. So the app has been running since 2022, and as you can see, we are starting to roll out across Wales. These are the features that are currently available. We have if you go to the next slide. Is on there? The English version. So we have GP practice appointments, the GP health record, prescriptions, and our Welsh identity verification service. We have moved everyone over from My Health Online now into the app, and we're currently moving everyone from the vision system into the EMIS system. So there's about 90 practices left to move over. On the bottom line, you can see we have My Health Journal, which is a place where you can write notes about yourself. It isn't shared with anyone, but it's a really good way of an aid memoir if you're going to for an appointment, or you've been to an appointment and you just want to make notes. We've also got linked to that is My Health Timeline, which is the chronological order of appointments, GP practice appointments, and we've just rolled out in the last week across Wales the hospital waiting list referrals and your first hospital appointments as well, out of the 6 of the 7 health boards. Cardiff and Vale will be the final one, hopefully in the beginning of December. But that, so for us, is a really big achievement to get into secondary care. We have the app available to download in Android and Apple, and you can see the QR code on the screen here if you want to download it, and at the back of the room as well. But we also have 2 website versions as well, one in English and one in Welsh. I should say that the app, the downloadable one, is also in English and Welsh as well. We do recommend that if people want to use other languages or need screen readers for sensory loss, then to use the web version. What we're working on at the moment is we're testing in actually Newtown and North Cardiff authorised access. There's property access, being allowed to look at someone's records if you're a carer or a parent. But hopefully once that's been tested, we'll be rolling that out further, because we do really see the benefit there as well. The other areas you can see on the screen are the Nominate Pharmacy. These are all to do with linking up with the electronic prescription service, so you don't have to go and collect a paper prescription. You'll be able to do this all electronically. We're also looking at prescription ready notifications and the shared medicines record as well, as plus prescriptions data tracker. Some of the other areas that are also of interest is patient captured information, like your patient reported outcome measures, and something called About Me as well. We're also looking at communication preferences and digital documents and test results. Again, these are in early stages. So again, hopefully within the next year, you'll be able to see those available as well. We've also just created a brand new dashboard, which is available for Welsh Government, RHCW health boards and GP practices. And over the next couple of slides, I'll just show you some of the information that's on there. So as you can see, we've actually got over 600,000 people registered to use the app within 2 years, which I think is really impressive. We can also see the number of appointments that have been made and cancelled, the number of prescriptions, and as you can see, I think there's 2.4 million on there. And we're also keeping a tally from each month as well. So on average, we think there's about 250,000 people are registering and using the app on a monthly basis, on a regular basis. The next slide really gives us a regional view and a map to show where people are registering to use the app. We had an aim to get over 600,000 by March 2026. We've actually beaten that, so which is a really good target that we've been met. Excuse me. As you can see, some of the other statistics on there, we've also got an organ donor register available, so you can use that through the app, and it gives you a record of where you were, whether you've already registered. Plus all the new total waiting list. So we can see in the last week we've now got over 15,000 people who've already got those appointments in the app. The final one is the Welsh Identity Verification Service. So as I should explain, this is instead of you don't have a passport or driving licence, you go to your practice with a Welsh Government approved list of ID. You'll be given a letter by your GP practice to allow you then to key in some codes, and then you get in through NHS login. So we've been running that since April, and there's over 5,000 people have logged on that way as well. And as you can see on the bottom, we can also see the distribution for that across Wales as well, and looking at from the rural areas as well as urban areas that we've been discussing this morning. And we can also drill down to GP practice level as well. I thought it'd just be interesting just to show what engagement we've been doing over the last couple of years. We've broken it down into what we do in Patients and the Public. I chair a Patients and Public Assurance Group, which comprises third sector organisations, LICE, and digital inclusion leads and patient experience leads from NHS. We're also really keen if anyone is interested in joining us. This is a way of assuring and evaluating not only the NHS Wales app, but other public-facing digital services as well. And also the conduit to other connections as well. So it's a really important group for us to make sure we are getting the patient voice into what we're doing. We've also set up user research panels, and again, if you're using the app, you might go into the feedback button. Please register if you'd like to be part of the surveys that we're currently carrying out. We also ask you to be part of any user testing as we're developing the app, but also as we go live as well. And that's a really good way of making sure we are listening to feedback as it comes through. Some of the other things we're doing are events such as today, but again, if there are any big events taking place that you'd like us to come along, we're more than happy to come along and demonstrate the app and get your feedback on it as well. We've also been doing demonstrations with different organisations. We've done a lot of work with our digital champions, which Dallas will explain shortly, but we're also trying to make sure that health and care professionals are also aware of the app as well. So you can see there's a lot of training that's now starting to take place within community pharmacists as well. And we've also developed a resource centre with lots of information on there, which again we want to build up on. And as you can see, the digital champions is a really big, important part for us. We want to make sure that as many people as possible can use the app, but also they have that local support in their community with trusted trainers as well. So,
hello.
Do
you want to?
Yeah. Sorry.
Issue with the clicker.
This way, I'll probably point in the direction.
Yeah, so I'm Della, as I said, I'm the Digital Inclusion Manager for next slide. Yeah, thank you. Next slide, please. Great. Wicked, brilliant. Fantastic. So I've just come into post. I've been in post now for 6 months. And it's really interesting to me that NHS is exploring these digital inclusion roles. And it's so important that we are now able to kind of take this forward in a coordinated way in RHCW. So the latest figures from Welsh Government show that around 4% of people do not use the internet or not online regularly. So that's across the whole of Wales. But most interestingly, the new way of measuring digital inclusion and exclusion within Wales is through the minimum digital living standards. This demonstrates that around 40% or more of families, so specific to families at the moment, do not meet these standards, and that's within the Welsh context. I think that it's quite a stark figure that number of families aren't able to sort of access the digital services that they should be able to. Digital exclusion and inclusion are both variable and intersectional. You may find yourself slipping into the excluded group or moving into the included group depending on a variety of factors, whether that is financial, due to your device becoming too old to be used with certain services, and or just many development disability, many different things. But we do know that people who are digitally excluded tend to be more frequent users of health services. So we've got a bit of a big issue here. Other current factors that we need to be considering include the speed gap. So we've reached a point in technological development where we're actually at a space where technology continues to increase and move up, whereas our ability as humans to adapt and transform to that technological advantages is starting to stall. So we need to understand how we can continue to grow these skills and continue to keep up with the technology as it emerges, including AI and all the exciting, interesting things that are emerging. We're also facing many challenges around data literacy, media literacy, health literacy, all those things where we need to make sure that the information we are providing for people is easy to understand, is easy to find, and is a source of truth for those people moving forward. Just thought I'd highlight this. It's really interesting, the last maps that we saw as well. This is the Digital Exclusion Risk Index. So this is something that Manchester University been developed within Manchester. This kind of shows another level of the maps that we've seen in the previous session, which emphasises the fact that services are in rural areas. 9 out of 10 of the most excluded areas included to this index are in rural areas. So, for example, Larn is the most digitally excluded area in Wales at the moment, with Cateys being the most included. There is almost a 5% sort of difference between those two areas. So more than 5% of a massive difference between those two areas anyway. So in terms of what we're doing at RHCW to try and tackle some of these things, we're a national organisation. We do have the app as part of our portfolio, but we need to work together to make sure that we can make the changes on the ground that we need to see. So we're building an action plan at the moment to try and tackle some of these areas, looking at digital leadership, inclusion leadership, how we can empower communities to support public health patients, staff, groups, clinicians, and looking at building skills across the board. We're also considering digital standards, so we're building towards a user-centred design approach within work. We are looking at ways that we can make our communication better, simpler, more inclusive. And we're also considering elements around social value and sustainability. So looking at how we can build digital inclusion activity into our contracts with commercial partners so we are able to give something back through that route, but also looking at how we as an organisation can develop services like digital champions as well, who can go out and support. So I thought it'd be really interesting if this works, to sort of try and think about an actual person within this situation and how we can maybe come up with some solutions. So on your desk in front of you, you should have a little post-it note and it will have a link to a form, or you can use a post-it note, so I'm not precious, whatever you feel like doing this day. But we're going to try and answer some questions, so Joe can move forward. Perfect. So we're going to be considering Ivan. He's 82, he lives alone in Falcon site. His GP practice is a 20-minute drive away, and he relies on his daughter to take him to his appointments. He has some digital skills and enjoys learning more. He wants to order some prescriptions. He does have some concerns about data privacy, and he prefers to communicate in Welsh. So you can scan the code, you can use the link that's on the sheet in front, the little post-it in front of you, or you can use the post-its. So just taking a couple of minutes now, you can discuss on your tables, you can do individually if you're sitting on your own. Just have a think about what some of these barriers are, and hopefully everyone might be able to join as well. And if you can drop a link in the chat, so we can grab it. Having a think just for a couple of minutes, what are some of the barriers that he's facing? What may be some of the benefits to him overcoming these barriers, and what would be some of the solutions we could come up with? Yeah. So and free to shout out suggestions and things if you'd like as well. It's what type of things do we think that would maybe work to support the situation? Do you have any ideas? Very quite rude to say.
Privacy issue. The number of passwords that we now have to remember for all the different apps and things that we do. The opportunity of using biometric data would be very, very useful, I think, for persons like this.
Brilliant. Fantastic. So that's the biometric data, and you'll see a lot easier.
Sorry, they can't hear that. Can you repeat to us?
Yes, so yeah, the back basically the comment was around using biometric data to sort of log and make it easier to access the app.
Just to say, we do have biometrics built into the app, so not on the web version, unfortunately, but if you, through Energy's login, it does allow you to do that. And that's one of the benefits, is that we're able to link a third-party systems through the app, so you don't have to keep remembering all these passwords. So.
Yep.
Can we just get the mic?
There we go.
Rural bus service.
A rural bus service, yes, that would be ideal. And how we can manage those, some of those community transport issues is always a big challenge within rural settings, and coming up with innovative ways to do that, and then also supporting the daughter then through and giving back more independence to Icon. That would be ideal. Anyone else? Any ideas? No? Okay, well, I'll let you complete those forms in your own time. We'll come up with some hopeful, interesting ideas and hopefully some interesting solutions. Still work. So what we're really looking at now is how we can build on the population that is utilising the NHS Wales app, and how we can make that best used within the rural communities of the services it offers, with the ability to create prescriptions, with the ability to make appointments, and all those different things that it does offer the opportunity to manage your own health as well. So we need to collaborate to be able to do that, and I think that is one of the really major steps of the next 12 months, is to look at developing those partnerships, looking at the capacity within rural communities, particularly to build and make sure we're reaching those people that really would benefit from use of the app. And it's also around embedding digital health inclusion support within everything that we do. So thinking about those social prescribing roles that work so well across Wales, and thinking now, how do we embed the digital element within these roles, and coming up with those resources together with the support of patients, so it's meaningful to them. And finally, it's also around centering the voice, most importantly, I would say, centering the voice of patient and public within everything that we're doing. And there's a lot of things that Jo is doing within that space, around the user panel, around her patient engagement groups, to make sure that patient voice is really centred within this, and that we are really enabling that user-centred design approach to come through, and the co-design of future features linked to the app. Hi. I think we have to wait for the mic, so sorry.
They won't hear you.
We won't hear you online, just wait for the microphone.
I don't know if it's not good enough to repeat back what you said, so apology.
I have a question that I'm with as well, so we have a way that I can relate to the context of what particular post. So, two things that I understand. I know that somebody, people can really just act or people cannot, but does it have ability to see all the results? Like, say, for a elderly who's living in a rural area, these could be either chronic medical condition, which may not be so urgent, or it could be like something urgent advice, we can take nearby dentist one-on-one. Yeah. But if out of all the practice are not open, but if they have not their results or anything, then they are equipped with the knowledge. So they can negotiate for the next day or whatever. So it's not only just the issue of transport, which is for a better language. It's empowering the patient about their results, what exactly they're finding. They don't need to travel to just to know what that results. You know, that's what. So that's what I want.
Perfect. Yeah. Yeah.
Yeah, absolutely. Thank you. That's a really good question. And actually, that's something we are looking at. I should have said within the app, we have the access to the GP health record, which currently allows you the summary care record, which is your medicine and allergies. But there's also another function called detailed coded record, which will allow you access to your notes, your test results, etc. But unfortunately, that's in the hands of the GP practice to make a decision whether you can see those or not. So we are working very closely with practices to see if they can allow that to happen. But yes, there's they've got on average the number of patients that they have within their practices. This has to be done by individual patients, so it does take a lot of time to do that. But we've been talking to EMIS to see if there's a way of doing it automatically, but would actually give you, I think you have 3 working days grace before the result is actually available for you to see.
That's great.
Thank you very much. Thank you.
The hospital is there to send information into the NHS England the panel sending information into the NHS Wales. Are there any plans to provide a similar service for Welsh patients in English hospital?
In English hospital, unfortunately, we're tied with the NHS login. I think there is a way of doing it, but again, it's making sure that the systems both talk to each other across England and Wales. So I know there's work going on in Paris at the moment, but again, yeah, there's lots more discussions for them to have access to other information as well. It's on our roadmap. Okay, thank you.
Thank you very much.
Thank you both. Really illuminating, informative discussion there, and probably opens up our eyes to the range of possibilities with the app. So really grateful for sharing those thoughts with us this afternoon. Okay, we've just got a minute or so before we move to the third breakout presentation session. Here in the Montgomery Pavilion, we'll be hearing from the Lampeter-based multi-agency team who are going to describe their experience of coming together cross-boundary and working together to address the specific needs of patients and enabling those patients to feel their voices are being heard. So looking forward to this conversation. Not sure if colleagues are going to join us back from the other room, so if we give it a minute or so. Yeah, but if you want to come up to the stage and set up, then we can be ready to go then one first. Delighted to welcome the Lampeter multi-agency team. So we've got a number of colleagues with us here in Builth, and we've got a couple of colleagues online. So we've got Vic Ellis, a neuro rehab specialist physiotherapist who's working in Hywel Dda. We've got Terry-Ann Patrick, a clinical care coordinator also with the Health Board. We are hoping that Dr. Mohammed Imam will also join us. He's a South Ceredigion cluster lead in that part of the world. And online, I think we should have Michelle Richards. We should have George Wilson and Deb Howlett. So quite a team who are really excited to share their experience of how they've come together across their organisational boundaries, really provide some targeted care for the needs of particular patients. Guys, happy that you need to come up. There's quite a few of you. You'll need to stand in front of the camera in order that colleagues online will be able to hear and see.
Good afternoon, everybody. I'm Terry-Ann Patrick. I'm here with two hats, probably. My role is Locality Development Manager for the south of Ceredigion. And I also, as part of that role, am the Clinical Care Coordinator for Lampeter Multi-Agency Team Meeting. Sorry, I've got clickers and all sorts here. Okay, so this is the story detailing the support provided to a really quite complex patient by a community-based multi-agency team meeting in Lampeter in rural West Wales. This showcases how an organic, collaborative, networked and person-focused approach can effectively address multifaceted health and social care needs. The MAT model described is rooted in relationship-based care and demonstrates the importance of integrating various services around the individual. The case study spans over 18 months and highlights the patient's journey through trauma, the collaborative efforts of the MAT and the lessons learned. Our aim here today is to inform and probably most importantly, inspire community-based teams working in complex contexts, offering insights into the practicalities and application of integrated care strategies. The strategic foundation for MAT approach in Lampeter is influenced by national level strategy, the Social Services and Wellbeing Act, and also we're probably all very familiar with Healthier Wales. At a local level, the Ceredigion Integrated Plan, as well as influence from the story so far from the Ceredigion Integrated Transformation Team. These papers all advocate for the same thing, for person-centred and community-based integrated care. MAT aims to bring together the multidisciplinary teams to support GPs in delivering patch-based, person-centred care. Delivery is highly reliant on excellent partnership working, the Health Board, local authority, private sector and primary care, where an ethos of the conversation is the referral is promoted. Multi-agency working is a key element, defined as collaboration among professionals with shared clients, involving information sharing, coordinated service provision and joint assessments. This framework supports the holistic management of chronic and complex conditions and emphasises, most importantly for us, the proactive and preventative approach. This sounds a bit posh, but we use risk stratification for early identification of needs and prevent deterioration and crisis. The success of multi-agency working hinges on trust, equality, shared understanding and effective communication, and the legislation underpins the MAT's operations and guides its collaborative ethos. The MAT approach is proven highly effective in reducing GP demand, minimising crisis response and preventing unnecessary hospital admissions. For those of you that are interested, we can send out our end of year MAT report that gives some equations around cost or potential cost savings in terms of potential bed days saved. So that's something that we could share, Anna, if you'd like. By delivering coordinated care through a network of professionals and agencies, many that are already known to the individual, MAT ensures timely access to support, advice and expertise. This collaborative model brings together GPs, advanced nurse practitioners, nurses, social workers, therapists and community connectors to address needs holistically. It manages complex and chronic conditions while prioritising proactive and preventative care.
MAT also acts as a conduit for complex case conferences, enhancing communication, reducing duplication and supporting integrated care plans. These multi-professional forums provide a safe space to discuss frequent attendance and complex cases and ensure person-centred solutions across health and social care. And a key component is patient empowerment, promoting self-management, lifestyle changes and early recognition of illness. MAT fosters independence and reduces reliance on acute care. So as you can see, we've got 4 stages of MAT there, and each stage was characterised by collective decision-making and alignment with the patient's perceived needs. For example, the physiotherapy team accepted referrals, verbal referrals, during the meetings, which streamlines the process and cuts down on red tape and bureaucracy. And the MAT prioritised access to narrative exposure therapy and addressed logistical challenges such as transport and physical accessibility. And this structured yet flexible approach ensured timely and context-sensitive support. Okay, so enough about the MAT. I'll hand you over, if I may, to the dedicated team that have helped to support and facilitate the care planning for our service users. So have we got George?
Hello, I am here.
Are you on Smyrna? Sorry, George, do you want to find out the stop share? George,
hello, can you hear me? Hello.
George, do you mind putting on camera?
Camera doesn't work.
It's on. It's on. Okay, does he want to talk?
Can you hear me, Terry-Ann? Hello? I don't know if you guys can hear me. You can hear me, marvellous. Rachel says you can hear me. So hello, my name's George. I work for the Integrated Psychological Therapy Service. And I'm a qualified cognitive behavioural therapist, and with the service user in mind, I was using narrative exposure therapy, which is a therapy specifically for people that have experienced multiple traumas. I will talk more soon, but Michelle.
Hello, hi, I'm Michelle Richards. I'm the manager here in Camvan, our community drop-in centre, and I also manage the float and support service, which helped support the service user we're going to speak about today.
Deb Howlett. I'm a community physiotherapy support worker, and I've worked alongside.
Hi everyone, I'm Vic Ellis and I'm a neurophysiotherapist and I work in the community services in Recordiad for Helba. I'm going to pass you over to George now to start our story. Okay.
Hi there. My camera doesn't work by the looks of things. I don't know why. But if you can hear me, I'll keep talking. So the service user in mind, 99% of our referrals come from the community mental health team. She was put on our waiting list for narrative exposure therapy due to the severity and the very numerous amount of traumas that needed to be processed. And then we started therapy. That's 90-minute sessions, up to 20 sessions we would offer, possibly even more. As we started the therapy, things got very, very complicated with physical health and mental health. I had no idea what a MAT team was at the time. I do now, thankfully. But I didn't know what a GP was. So I contacted Dr. Iman, explained the complications. He was very supportive of the therapy. And then he triggered the MAT process. Due to the severity of the traumas and how many there were, it's a really bad idea in my job to start trauma therapy and not finish it. We don't start the therapy unless we're very sure we can finish the therapy, as sure as we can be. And I was very worried that we were going to sort of open that can of worms and then not being able to deal with the worms. So with Dr. Iman's support and the MAT's support, they allowed me to finish the therapy, which was vitally important that we had a good ending. And that would definitely not have been achieved without the MAT team. I mean, like the physical health and the mental health got very complicated as we went through the therapy, and thankfully we did have a positive ending to the therapy with less PTSD, should we say. Also, additionally, because I'm a cognitive behavioural therapy, we use behaviours as much as thoughts and beliefs to help people process their past. And without without sort of very regular contact with Vic as a physiotherapist, she advised me how much I could, what behaviours I could encourage and not to go too softly, which is very important for their recovery as well. Also, I'd really highlight that I was seeing this person for 90 minutes at a time, and we went way over 20 sessions. And there were some very specific things that was very important to this service user. And other mental health or other healthcare professionals would always ask the same questions, which would make her feel very invalidated and very annoyed, and then not really want to work with that person. But it took me 20 sessions to understand why she always said those things. And then I could give Dr. Iman and the MAT team a very concise reason why we don't ask those specific questions and don't keep asking the same thing. And then that patient finally felt heard, and finally felt listened to and understood and respected, because people stopped asking what she felt was stupid questions all the time. They finally stopped asking those, which might appear like obvious questions, but they finally got it. They finally understood. And then we could work effectively as a team, and she allowed them to work with her in an effective manner. I would also point out that I wouldn't have been able to do that. I mean, I was one person in the MAT team, but I'm part of a wider team. And due to the severity of the traumas, I had very specific trauma supervision, and I had normal supervision, and I had peer supervision. So I was incredibly well supported to support this person. And then I could give a concise outline of the trauma. I didn't need to traumatize the MAT team, but I could give a concise version of the traumas, and then they understood how to work with this person. And then very eloquently, she's given permission for us to read out her direct quote when Vic, our physiotherapist, was interviewing her afterwards, which I will read out to you. So, listening is not hearing. And this is her quote. I've had a history of trauma since birth, varying degrees of trauma from childhood right the way through to adolescence in care home facilities and foster situations where you'd expect a higher level of care than I received. But it doesn't matter who's involved, and it doesn't matter how much you've been through and how much they profess to help. It makes no difference whatsoever if you're not heard. If no one takes the time to understand, it's one thing listening and it's another thing hearing. They're two completely different things. If you're not heard and only listened to, nothing helps. You can listen to the radio, but do you know the words of the song that you're listening to? Because if you're not hearing it, you're just listening to it. Suddenly, for somebody to actually get it, it's big. So thankfully, that was me, that I finally got it, and then I could relay a concise version to the MAT team. Have I forgotten anything, Terry-Ann? I can keep talking, but I think I've...
So, as George said, this was a very complex case, and I'm a non-registered member of staff, and I was asked to come and be part of this team, to be another face that could be trusted. So I didn't actually attend any of the MAT meetings. It wasn't important for me to be in the room and hear all of the information. What was really, really important was the communication of the whole team down to me when I was going for my interventions. So Vic, who I work really closely with, she talked me through what was needed and what was required from me. And we planned really, really carefully that we would go together to introduce me so that I could become a safe place and a safe person to interact with. Like all brilliant plans that had been laid in stone, and this is how we're doing it, this is the way, it went completely awry. And I ended up arriving at our service user's house by myself. And I knocked on the door, and the door was opened, and she disappeared to the far corner of the room. And her first instruction to me was, "Don't come in." And I heard it. So I stood at the door and I spent 5-10 minutes saying, "I'm just here to check and see you're okay. And I was coming to make sure you're still able to get in your shower," practical things like that. And absolutely no way was I allowed to go in the room. And the whole interview ended with me saying, "Okay, well, if you're sure you're fine, that's great. I shall head off now." And I was given another clear instruction. "You must do the catch on the door, slam the door, and I want to hear you walking away." Okay, that's fine. Flick the switch and shut the door, and off I went. And that was another key thing about this whole process. It made me think about respect for the person's narrative and the person's story, and respect for the other individuals within our team. We all brought something to this process. And it was very empowering on a personal level, because my contribution has been equally valid and equally respected by every single member of the team within it. So as individuals, the personalities of the people involved is important, because that trust level and understanding of how to move something forward safely is, I think, integral to a MAT working really well. And I feel very, what's the word? I'm very proud to be a part of this process and working towards a better outcome on a very patient-led intervention. And I'm now going to hand over to Vic, who is
there's been lots of mention about boundaries today, lots of questions about boundaries. Well, we're describing a group of people where the boundaries were blurred. And I think that's a really important message. There weren't professional boundaries. You could actually put us all in a room and it would be hard to tell who we were and what we were doing at the time, because it became so mixed. So I, as a community physiotherapist, became involved at the request of this lady's GP. And I attended the Lamperton MAT meeting, and there were some very clear rules communicated within that first meeting, and they came from George. And George had spent, I don't know if you could hear how many hours that he has spent getting this story and hearing it and understanding it in that person's words. And then he communicated it to the rest of us in a concise version of simple rules that were not to be broken. And from there, we created a plan. And my plan from the team was very clear. My job was to help this service user get to George. From a physical point of view, the process of getting from her home to George's clinic, she wasn't able to go because of the practical difficulties. It involved a flight of stairs that was difficult for her to negotiate, getting out of her property to a vehicle. From the vehicle she was travelling 30 miles. For somebody who had physical and emotional and trauma experiences, this was a big deal, living in such a rural area. She travelled 30 miles, and on the other end, she needed to be received with a wheelchair. She needed to be able to wait in the waiting area, and then she got to see George. And then from working with George in her trauma therapy, the whole process had to go backwards to get her back home. And by the time she was at the point of getting back, she was aching. Her physical problems were more challenging. She was more unsteady on the stairs, and we had all of those issues to work through. So I was guided by this team in the context of the difficulty, and I remembered the purpose, which was to get to George for the trauma therapy. From getting to George and having this care, the hope then was that as a collective, we could, as a community and primary care collective, we could improve her ability to access all the other services, such as the secondary care specialist service that were involved in her care. So we had a very clear plan, and if I had not known the context and all of the story from George and the team, and I had taken this situation out of context, it would have been really easy for me as a physio to go and have a look at her walking up and down the stairs and tick a box and the job was done. But I remembered the actual need behind this, and the need was for her to get to the trauma therapy, and from there for us to support her management of all of her other long-term conditions. So it was a real privilege to be part of this team, and the way that this team has worked. I'm going to use the word equity of access to services, because it's been mentioned throughout from the very beginning of today. This is an actual work in progress of an example, a clinical example of how we have pulled out all the stops in order to achieve equity of access, which would not have happened. So I don't know if you heard George say, his trauma therapy would not have been concluded at the risk and detriment to this lady if we hadn't have worked in this way. So that's a really important message that we have achieved. However, as George said, the amount of time in addition that he gave to achieve this is another issue that's been raised this morning, to do with the actual financial increase in financial resources of working in a rural area to achieve this equity. So my time has also been spent in supporting this, which goes above and beyond probably a lot of other cases. Another point that Terry-Ann, where we claw back some of our time, Terry-Ann mentioned that my community physio service is very proud that within these conversations and in these multi-agency meetings, we accept the conversation as the referral. So we don't need a piece of paper, we need to be part of the conversation, and we respond to the needs, and that tries to cut down the paperwork and speed things up. So the actual paperwork is done by us within the conversation, and then any gaps in the paperwork that we don't have, our lovely GP surgery administration team sends us the gaps that we need. So we try and cut down that bit in order to be able to spend more time on the bits that matter. I also, I'm going to introduce you to Michelle again. And Michelle, I met Michelle through this case, and it was an absolute privilege for me to have worked with Michelle. Because of the level of trauma involved in this case, and me being a physiotherapist, I really needed the expertise of George and Michelle and all of this team to guide my decision making. And it was a privilege, because as a physio, I very often in my role do not have easy access to the expertise of the people within this forum. So Terry-Ann and her team allowed something to happen that was really rather special and really rather important, and something that needs to be known and understood. So one of the things that I gained from Michelle, we spent a lot of time over many months collaborating, was during emergency situations where we had a number of emergency episodes, and because of my frequent contact with this service user, very often I was the person that she contacted, and I needed to have a safety net and a way of escalating the concerns and for us to work through as a team. And Michelle and her team and her services that she represents blew me away by the amount that they knew about this person. So this is a local service, local to Lampeter, and the care that they provided was incredible. So be careful, Michelle, with what you're going to say now, because over to you. So thank you, Michelle, for all of your knowledge, and hopefully we're going to be able to hear from you.
Yeah, okay. Thank you. And I think that works both ways, because we are a voluntary sector here in our mental health drop-in, which is the Kanban aspect. So when the service user was phoning quite distressed and kind of panicky, nobody was helping her, nobody was doing anything, knowing what the MAP team were actually doing to support the physical health and the mental health reassured us that actually everything was in place and it was just about reassuring your service user at the time. Unfortunately, the service user was unable to physically come into Camvan, the community drop-in, where she would have normally taken part in arts and crafts and mixed with peer groups. We were only able to offer telephone support. That said, we were still able to provide takeaway meals and stuff, so that it provided her with healthy, nutritious, warm meals that she didn't feel capable of eating at the time, and gave her that reassurance that people services cared. And having just that little takeout meant the world to her, which she would phone and thank us very much for doing so. In addition to our mental health drop-in, we have a floating support service, which primarily focuses on housing. Unfortunately, the individual was in a place that just wasn't suitable for their physical or their mental health. And after 18 months of trying social housing, looking at private rent, we were just drawing a short straw until the perfect place was found, the place the individual was their dream home. Finding that, thankfully, she managed to find it herself. It was the dream home. Giving us a week, 2 weeks to get everything into place. We managed to help her secure the bank statements, to get the discretionary housing payment grant in order to help the move with the rent and stuff. So all that was covered. Making sure that the utilities and stuff were closed with the old property and moved to the new property. So yeah, so there was a lot of paperwork from the housing side of things, but it was so worth it to see that this individual now is in a dream home, and just the difference that the MAT team have been able to make to her is absolutely amazing. So thank you to each and every one of you, especially Health Board, for including us, because again, as I said, we're a voluntary sector. This is unique to us, but your expertise has been absolutely amazing for the service user and also for all the staff that work here in Camvan and for Pobl. So thank you very much.
You'll all agree stories between all of the professionals and the role that they've played in making this happen. So what did this mean for the service user? Person-centred listening. So the MAT journey began with professionals taking the time to truly understand the individual's story. And at the heart of the process, myself and the advanced nurse practitioner, who's also based at the GP practice, because of our proximity, we were able to work very, very closely together to bring together all of the right professionals in order to be able to support this really quite vulnerable lady. In terms of our approach, we were very flexible. We evolved organically around the person, bespoke to the needs of the service user. So complex cases like this require continuity of care, and as you've heard, it takes a huge amount of time investment. The service user expressed frustration constantly with professionals lacking knowledge around her history, her really quite complex history, and this led her to feel constantly misunderstood and, most importantly, unheard. The MAT mitigates this. It ensures consistent communication and information gathering, and everybody that then becomes involved with this, with the service user's case, has all the information and the history that they require, so that they don't feel the need to ask, and as she put it, silly questions. So the MAT filled gaps in social connection, acted as a surrogate support network for this lady. So the MAT model exemplifies integrated care in action, enhancing collaboration among diverse professionals and improving people's outcomes. It supports system sustainability by reducing reliance on acute services, promoting proactive engagement. Frequent attenders to the GP surgeries and emergency departments also benefit from coordinated care plans developed within multi-agency forums. Patient empowerment is a key component, encouraging individuals to manage their health through lifestyle changes and early recognition of illness. The presence of various services in MAT meetings ensures a holistic understanding of each person's circumstances, and this transdisciplinary approach places the individual at the heart of everything that we do, fostering independence and reducing duplication across services. Just going to leave you with this last slide that Vic will present to you. Thank you.
So we know that the person's voice is at the heart of this, and to prepare for today, we asked for and received informed consent to present today from this lady, and I spent some time with her and interviewed her and audio recorded on a dictaphone and transcribed, and then I went back to her last week and we finalised this presentation. And we've formed this presentation around that interview and around a collective group conversation of our reflections in hindsight from the lessons that we've learned and the organic process that we went through. So this lady has given her informed consent, and this is a representation with her at the heart of this. But she has said to me for me to remind everybody that when services don't work in a connected way and are not joined up, it's really hard for the person at the centre of this. And she says that when the person's story isn't heard and there isn't time to hear it, and there isn't a team working together, it can feel like you're a problem, not a person. But as a positive finish to our presentation, because it really, hopefully you can feel that this was a really positive time for her and for all of us working together. These are her words. She said, if everybody gets together, then everybody sings from the same hymn sheet. When the people who are working, when the people who are hearing you get together and discuss what they can do to help you, things happen, things move, things improve. And we as a collective believe that in presentations like this, you end with a slide that says, any questions? But we are ending with her voice. But we also say, invite you to any questions. So thanks for listening.
Sarah-Ann, Michelle, George, Deb, thank you so much for a wonderfully inspiring narrative and story and sharing your experience. I think it was positive all the way through, so it wasn't just a positive ending. So many things struck me about that discussion. Your steadfast refusal, I guess, just to refuse to allow obstacles, be they professional, bureaucratic, organisational, those sort of boundaries, if you like, get in the way of doing the right thing. And you've really shared with us an experience there, putting the person right at the centre of your thinking. The other thing that struck me, I guess, was your care for each other as well in plotting that journey. So really grateful for sharing that experience with us, starting so many lessons, I guess, that we can take forward and really challenge our thinking into how we deliver that quality of care within a rural environment. Thank you for sharing that. Okay, I think we're at the point where we now need to move to plenary session 3. Really, I'm just going to check here that we have our friends and colleagues from Alberta and Canada on the line. I can see a couple on the screen, so I'll introduce them in a second. So just checking whether everybody online is regathered in the main plenary room. So we may have a couple just what I might do, guys, I might pause you for a second, just to allow colleagues who've been journeying back from the other breakout rooms to join us, so that we can allow everybody to share the experience that you're doing part of us this afternoon. Alberta in Canada. Very mindful that we've not long finished lunch here in Wales. I think it's 7 AM or so in Canada, so it's probably coming up to breakfast time. So I'm really grateful to colleagues for the early start, and apologies for subjecting you to that. So hopefully on call from Alberta, we have Helen Lightfoot, Amanda Panziak, Kim Larson and Sharon Cornelius. Hopefully I've got you all in the right order there, who are really going to share with us their experience of connecting people and communities for living well. I'm going to share with us experience of two multi-sector collaborative teams working in Alberta, who come together to build health, social and community support for patients. I did a little bit of research this morning. Surprised me actually that the population in Alberta is not dissimilar to the population in Wales. But surprise, surprise, I guess, the land mass in Alberta is some 30 times the size of Wales. So that just really highlights the geographical challenge that the guys on the call encounter in describing and delivering the care that they're going to share with us. Guys, very welcome and great you can join us. If I can just ask colleagues in the room here in North Wales to show their appreciation for your arrival.
Thank you so much.
Anna,
do I
hand over to you first?
To Helen, yes. Can you hear me?
We can.
Okay, the share button on Teams is not lighting up, so I'm not able to share our slides right now.
Do you want me to share them, Helen?
Sure, sure. Why don't we go with that? That's great. Thank you. Yeah, we can go to the second slide there. Thank you. So thanks so much for having us back actually to this conference. We've had the honor of presenting for a few years now, and it's been great to be able to kind of share our progression. Our work started with a Health Canada grant back in 2020. And I guess just wanting to emphasize that the center of it has been around well-being and impacting people's well-being. It's focused on bringing together people within rural community teams to be able to support people living with dementia and their caregivers to have the best well-being and as well as staying within their communities. Yeah, so just that context of Alberta, we're one of the provinces, we're about 1,500 kilometers from tip to end. And so what we find within rural communities is that people often have to travel 1 to 2 hours to receive services. And within rural communities, there often are not any supports for people living with dementia and their caregivers and generally older adults. And so the purpose was to help these teams build some of those supports locally. Next slide there. You can just bring up the next slide. Maybe as it's coming up, I'll just say we have 12 community teams that we're working with. And when we see that move along, you'll see 2 big blue dots, and those are the 2 teams that are going to be presenting today. We have brought together health, social, and community partners in doing this work. They had a little bit of seed funding, $6,000 to work towards implementing supports there, but also brought much more monetary funds in through fundraising as well as applying for grants there. If we can just move along, Anna, for a couple of slides. Maybe it's not working as well. I guess my next slide is going to be of our model. I'll just talk a little bit, even though it's not up there, but to say we've learned a couple of things, and I've shared this model at this conference before. The central point of it being around well-being. We have an aspect that we call provincial support, might be termed regional support in Wales. We've seen great growth in that area in terms of other partners coming alongside. Initially, it was just us as a grant team that provided that provincial support, but we now have Healthy Aging Alberta, which provides support to community-based senior serving organizations. We have Caregivers Alberta that supports caregivers, the Alzheimer's Society of Alberta also. And so that support is building provincially a broad kind of support system for the local communities. I also wanted to just highlight, we've got a section called Communities Advancing Local Work, and how essential that has been to bring the voice of lived experience into this work also. That's really key for those teams, as well as having the health, social, and community partners working together. We have our core principles, and the key one to me is that it's community driven. So our initiative lives within the health system, but the decisions, what gets implemented is decided by that local team. And then we have two other parts of it, being the wellbeing guide, which is a resource for those community teams based on some research that we did. And then the final area is really in learning areas. So what is it that helps teams to be successful? And one of our big learnings around that actually is that it takes learnings at that team level, but it takes learnings at that provincial, regional level that we talked about, but also at the system level. So things like how to collaborate, information about asset-based community development, person, environment, fit. So that learning is needed across all three levels to be really effective, to be able to implement the supports that they have been working on. And I don't know if we're able to bring the slides back up. The final one that I had to speak to, and then I'll hand it over to Kim and Amanda, is around a multifaceted approach to evaluation, and that we've needed to really look at how do we look at this from different angles so that the different partners who are involved have the information that they need. So we have case studies. We had a return on investment for the healthcare investment, which was $1.60, but we also did a social return on investment, which came back as $6.34 for every dollar invested, and really emphasizing that the benefit, the value to those people involved, people living with dementia and caregivers, equaled that to the public system there also. So we are handing over to Kim and Amanda for them to tell us about what they have been working on in Drumheller. And I'm not sure if we're able to bring up that slideshow.
Thanks, Helen. We'll work to introduce ourselves. My name's Amanda, and I'm a primary care nurse with the Big Country Primary Care Network, and I work out of our physician's clinic in Drumheller.
And I'm Kim, and I'm a wellness coordinator and community liaison coordinator, also with the Big Country Primary Care Network. And I cover the communities of Drumheller, Hannah, and Three Hills. So I'm in Drumheller 1 day a week, and I also work out of one of the physicians' clinics in Drumheller.
And so as a team, starting back in 2019, we were able to receive the funding and support with Helen to create our Community Seniors Coalition. So the Drumheller Community Seniors Coalition. And we are a group of currently 4 who are working together to form or to work on filling the gaps and needs of seniors in our community. And we come from a diverse background. Kim and myself are through primary care. We also have Karen, who is the Town of Drumheller Seniors Services Coordinator, as well as Liza, who works with Recovery Alberta as our Seniors Outreach Nurse. Through our group, we are strong advocates for seniors in our community. We've really learned to overcome adversity, and we are really creative problem solvers. So we've really used our local resources to problem solve and create what maybe was missing in our community. But we also like to push the limits a little bit. We like to go against maybe the norms of what you would normally see in your community and in your roles. So a bit more about the town of Drumheller. So Drumheller is largely known for its tourism and its culture. We have the world's largest dinosaur you maybe have heard of. We are supported by agriculture and the oil industry, but we have a growing population of older adults in our community. They're people who are choosing to retire, maybe where they grew up, so moving back to Drumheller, but also those from the bigger centers who are choosing to move to Drumheller because of more affordable housing and that kind of slower pace, easier to navigate community. We're a rural community, but I would argue that we're a remote community because we are about 2 hours from our big center where our specialty care would be. So the challenges in our community when we first started our work, housing was a challenge, lack of community supports, lack of community programs, as well as just working in silos. So before we had our group, we really were all working at this individually. So our group has really come together to coordinate services, to fill those gaps, and also provide some consistent programming for our residents.
Okay, so that's where I come in. So my role is to meet with people one-on-one in the clinic setting to help them work towards goals to maintain their independence and allow them to continue to do the things they enjoy as they age. And so part of that is navigation and resource finding. The other part of my position is community group programs. So Amanda had found that there were people, maybe new diagnosis of dementia, that were coming to see her, and there was really nothing in the community to refer them to. So through our coalition and with the support from the Connecting People funding, we formed the Circle of Connection Day program. So that is a weekly program for 2 hours every Tuesday. The location is the Drumheller Public Library, which is a space we're able to utilize for free. And the goal of the program is twofold. So we provide a safe and welcoming environment for people living with dementia or those at high risk of social isolation, living in the community to come and engage in social interaction, promote physical well-being, and increase cognitive function. The other goal is to provide an opportunity for consistent respite care to caregivers in our community, and that's something that is a real struggle in our area. So how that looks is the morning of the program. Every Tuesday morning, I call our participants with a reminder and an invitation to attend. We have found these phone calls really do help motivate people to come. So sometimes as the aging process happens, and especially with dementia, people do tend to isolate in their homes more. And so they do need encouragement to come out to try something new. We line up transportation, and again, we have some grant funding to cover that cost, and that also kind of takes that organizational piece out for the participants. We line it all up, we tell them what time the bus will be there, and they just have to get on. So I meet them at the library, and really for some of our participants, this really is the only time they leave their home all week. And for most of our caregivers, it is the only respite they have. So it's not a big amount of time, but it is something. When we're at the library, programs are planned around seasonal themes, special events, those sorts of things. Physical activities are also a piece of what we do. They're not always their favorite, but it is really important. So we try to make it fun. But the part the participants look forward to most is the coffee social that rounds out the afternoon. So we supply coffee, tea, and treats and gather around the table for a good visit. Participants enjoy the chance to chat about the day's events and what might be coming up in the weeks ahead. Our first program back in 2021 started with 4 participants, and it's been growing ever since. So Amanda does that initial screening. She's the initial contact at the clinic or in the community, because we do want to make sure that people are appropriate for this program. It's not a general drop-in program like you might find at a senior center. It's really specific and targeted to support this population. And we have worked up from there. So we currently have 8 to 10 people every week. And so one thing that's been really key to the success of this program is the effort made to remove barriers. So anything that might keep people from attending, we really try and negate, look after. So transportation is arranged, paid for by grant funding. There's no fee to attend the program. Supplies are purchased with grant funding. And we're going to talk in a minute about outings, and all entrance fees are also covered. So we really strive to use a person-centered approach in this group. The goal is for each participant to feel valued, heard, and appreciated for their uniqueness throughout each program. In doing so, we've built a strong rapport with the participants. They trust us to provide them a positive experience each week, and we've really watched a group of strangers become best friends, almost like a family. For some of our participants, this group is really all they have, their whole social and support network. They watch for each other every week. They ask if someone's missing. They may not remember names, but they do remember how this group makes them feel. They matter here, and that is really something special. So the other piece of our program is called our Memory Cafe, and that's where community integration is a real focus. So we really want our participants to feel like they still belong in their community and that they are welcome in different venues. So they've become a little bit unsure of how to navigate what maybe once was a familiar task. So maybe they would go to the movie when they were a young person, and over time they've kind of lost that, and they just don't know really kind of how to start or where to start. So work is done behind the scenes. We contact the venue that we're going to go to every month. We kind of explain a little bit about our group, what the staff can expect, what the staff can do to help make this a successful outing. And participants are willing to attend because they know that I will be there or Amanda will be there to meet them. So they know, they trust us to, again, kind of navigate any sort of issue that might arise and to provide a positive experience. So we visited places in Drumheller such as Barney's Adventure Park, where participants were treated to pig races, a petting zoo, rides in a John Deere Gator through an interactive dinosaur walk. The Valley Learning Garden, where we watched the rays go from worked up dirt in the spring to flourishing vegetables in the fall that the participants were able to take home. So again, it's that feeling welcome in your community, feeling like I still belong here. So although my abilities, cognitive and physical, may have changed, that I can still go to these venues and feel welcome. So the Napier Theatre, our movie theatre in Drumheller, has been a really big one. And they actually, initially, we approached them to see if we could host a seniors movie for free for the community. And they've kind of taken that and run with it. So they find sponsors every month, and they do a special deal for popcorn and pop, like a combo deal for seniors. So it really has made an impact on the participants, but also the community as a whole. We have watched different businesses and venues become much more open and encouraging for our group to attend. So we're not quite there yet on the slides. We are right about back a little bit more. Right there. Okay, perfect. So that's those are just a few pictures from our Circle of Connection program, as well as some of our Memory Cafe outings. So we can actually go down one more slide. There's a volunteer slide. Oh, sorry, caregiver support. Okay, very good. So back to kind of, this program being an opportunity for respite for caregivers, we also recognize there was very limited supports for them in our community. So no opportunities to network. We could provide them one-on-one support, but really that idea that you're not alone and there's other people that are in a similar situation to you, we found was really key to those caregivers feeling more able to continue that role. So through the Connecting People funding, we contracted a gal in the community to provide a facilitated caregiver support group every month. So Amanda and I both refer people to that program. And Angela is the name of the gal, and she provides a different topic every month for discussion, but there's also time for just open sharing. So sharing successes, sharing challenges, networking, how do I line up home care, or how do I find respite, those sorts of things. So that's been a really important piece to supporting those caregivers and allowing them to continue that essential work they do. So who else do we need? So one of the secrets to the success of our program has been volunteers. So to run a successful program with the objectives we have, you need people to support it. So those who are willing to jump on board, who really do believe in what you're doing. And these gals bring all the fun and the extras, a helping hand, the snacks, the coaching, the coffee making, all the extra things that help the program run smoothly every week. We've been very purposeful in who we've recruited to volunteer with us. So they are all retired nurses with experiences that give them a foundation for caring. So they are invested in this program, they plan their lives around it, and we really couldn't function without them.
All right, moving on to our in-home support programs. So like Helen said, there has been funding through Healthy Aging Alberta, and this has allowed us to provide some in-home support services. And so what that means is that we realized at the clinic, meeting with participants or meeting with clients and patients at the clinic, that although we can meet with them at the clinic, talk about their health needs, we really needed to focus on what was missing at home. So our frozen meal program, our hot meal program, we really knew that adequate nutrition and consistent balanced meals keep people healthy. So currently there's about 30 people on my call list, and we're serving between 15 to 20 people with our frozen meal program. And what that means is that once a month they place an order and it is delivered right to their door of prepackaged frozen meals, which they just need to reheat. So easy and quick for them to reheat. There isn't the planning of grocery lists and grocery shopping and prepping a meal. And they are well-balanced meals. Now, they are subsidized, our meals, both hot and frozen meals, with a subsidy up to 75%, and it's based on their income. We realized that people could not afford their meals without subsidy. And this really, the frozen meals especially allow us to reach our rural communities, so our even smaller communities outside of Drumheller that don't have access to the grocery store or to restaurants. Our hot meal program is provided by one of our grocery stores who pre-packages and makes hot meals ready to deliver 3 times a week. And participants place their order each week and it is delivered right to their door. So we have a delivery driver who takes it right to their door. We're serving about 18 people per month. The benefit is the in-person connection. So the delivery driver, that friendly face that comes to the door, it's someone who does care about them, that checks in on them, and it becomes again a social connection. The delivery driver also becomes our eyes on that participant, seeing them every week and noticing if maybe something is amiss, if something is off. Grocery delivery, and that's next, again, is the opportunity for us to reach people in those rural areas and provide groceries delivered right to their door. So again, this really, we have the biggest uptake in the winter months where someone maybe manages really well at home, but they're uncomfortable driving in these snowy conditions as it gets dark earlier, those unpredictable, driving conditions. So again, we have about 10 people in our rural, even more remote than Drumheller, remote locations where we can get essential groceries and supplies out to them. Next, we have our snow removal. And so it seems like such a simple task to, shovel the sidewalk, but what a big safety impact it has for participants. So we offer subsidized snow removal so that they can get out of their homes and to our programs. But it also allows people to safely get to the door, again, to deliver their meals or deliver their medications. But it also ensures cleanliness in their home. And this is something I didn't realize at the start, is that they need to be able to get the garbage out to the dumpster and not have it pile up in their home and not have unwelcome guests in their homes. So that was a bit of an eye-opener to me as we started working on these in-home supports. The last piece for us is our housekeeping, and that's up next. And so we have a private service provider, Helping Hands, who goes in and can do light housekeeping for participants. So this looks like cleaning the bathroom, mopping the floors, doing the dishes, doing the laundry, really ensuring that their home remains a place where they can be comfortable and that those, again, essential needs are met. This is, again, often more than just sweeping the floor. This also becomes a social connection and an opportunity for us to provide extra resources and information in those homes. It's a really gentle way to introduce in-home care, you know, having someone come in a really non-threatening way to do the laundry or to clean the bathroom once every couple of weeks and build that trusting relationship. You know, we really can expand from there.
Okay, so another initiative that we've started, again, with assistance from Helen's Connecting People group, is to host an annual seniors fair in our community for those who are 55 and over. It's hosted every September. We usually have about 4 presenters every time. There's resource sharing, there's vendor tables with organizations that support older adults. Networking. So our goal this year was inspire, connect, and share. The other purpose of the Seniors Fair is also to just allow people to learn about what is in the community to support them. It made our coalition a lot more visible. So we're known as like the purple shirts. We all have these matching shirts with our coalition logo on them so that people do know. So what do I do if I notice changes in my mom or my neighbor, or something seems off? What do I do? So it just really helped people kind of know who to contact. And we really wanted that kind of no door is the wrong door approach. So any member of our coalition can connect them to resources, can kind of get them involved in our programs. And the benefit of myself leading a lot of these community programs is that I can loop it back to the clinic. So if I notice changes or something doesn't seem right with one of our participants, I can loop back to Amanda, who can then kind of initiate some investigations at the clinic level to make sure that we are optimizing those health outcomes, which then again enable improved well-being outcomes as well.
Onto our next slide there. So we're really proud of the work we've done over the past, you know, close to 7 years on our initiatives. We have 18 community partners and it's growing. So for a small town like Drumheller, we're really proud of how well the community has bought into the work we're doing and how important it is. But these are the faces you see. And there's a link on the next page to a video that really shows our story. You know, we are improving the health and well-being of seniors in our community. We are their voice and they feel seen. They have found a group and a community that they again belong to. We can prove cost savings in healthcare dollars, and we can also show improvements in health and quality of life outcomes. But most importantly, we can prove that this collaboration and home supports provides hope. It's hope for people for a better tomorrow, hope for friendship, laughter, and joy. Thank you.
Thanks so much, Kim and Amanda. We'll bring on Sharon now to share about the Westview Dementia Collaborative. Are you able to come on, Sharon? Oh, I hope she's not having trouble with her mic. Are you there, Sharon?
I don't know whether you're able to just help me more.
Don't worry, not able to hear that. Maybe I could start a little bit on that as Sharon is trying to get her come off camera and her mic. I think she's probably having some difficulty with that. Maybe if you could bring back up the slides, I could start a little bit on that as she gets that figured out. I know a little bit, but Sharon will have more rich knowledge when she's able to join. The Westview Dementia Collaborative actually covers 3 areas within that geographic area. There's the town of Stony Plain and Spruce Grove and the Parkland County. They have formed the dementia friendly community. The first logo was the first logo that was designed for them. And then as they've progressed, it's come along a little bit with that. It's really at looking at how to provide support, resources, and collaboration within their community. It started with a little bit of a research project to reach out to people living with dementia and caregivers within their community to hear what was important. And a big part was transportation, connection, and recreational activities that were part of it. This next slide is of Chris Nelson, who is a key person within the community who has been living with dementia. I think it has to be over 20 years now. And during that first phase of the work that they were doing, Chris participated in developing business-friendly, dementia-friendly business videos. And so was able to speak to what helped her and her environment to be able to access places like banks, restaurants, grocery stores, and needing people to take things a little bit slower, make the environment a little bit less stimulating, but it had a big impact within, especially the Stony Plain community, where they provided, where changes were made within those businesses in that way. And so that made a big impact and also raised awareness around that there are people living with dementia within those communities and how to accommodate them in their everyday lives. On to the next slide there. So one of the things that grew right at the beginning of it is what they called their Dementia Connections project. And this has become a partnership between the Westview Dementia Collaborative and their Family and Community Support Services part of their town, as well as the Primary Care Network. And it has they have been able to jointly fund what they call dementia connectors. And so people living with dementia and their caregivers can access this person who then helps them navigate the resources and services and tap into what is available within the community there. Just looking here for... And that has taken a project manager, some project support, as well as the community connector there. The main features of that program is to be able to build those connections. And it's really helped people to become included within the everyday activities within their community, as well as building their capacity in terms of being able to access some of the programming that is there. And as well as being creative in terms of what programming had been developed. So there really weren't any programs before, but they've developed things like art programming. They've got a walking program. The recreational center has provided what they call Minds in Motion programming. Oh, I see Sharon is back with us. Sharon, are you able to?
Can you hear me?
Yes, we can hear you now. Just talking about... Just onto that building connections and building capacity slide there. So if I'll let you take over.
Okay, great. Thank you very much. And sorry about that. I was visible before, but anyhow, it's been wonderful to work with this program over the last, I don't know how many years. But I've really seen it grow. And one of the things that we started with is we wanted to make sure that the stigma about people being out in the community, just like what was mentioned by Kim and Amanda, the stigma is gone. So people can be out and about in the community. Some of the things that we have done to support caregivers, which is a really good, important part of what happens with our program, is we've created caregiver packages. And in that package, it has a list of resources within our community, a thank you card, a bag of tea for a cup of tea if they want it, and also a gift card for Tim Hortons. And there are a couple of other things there about self-care for the caregiver. So we've created these packages and we're distributing them them around the community. Very well received. They really quite like it. The support group is another one, and this thanks to the Alzheimer's Society of Alberta Northwest Territories. They look after this once a month. And I've heard from several of the participants in the different programs that this is this is a great way to connect and be part of the community and have that opportunity, as was mentioned by Kim and Amanda, that to express their concerns or have a good chit chat or just be away and do something different for a while. So all of our programs are around the dementia end of it. So that is very much the focus. Arts and recreation programs, we have a variety of, as you can see in the picture here in the slide, those are a few individuals that have been part of our creating connections through art. And not only does the caregiver come in and be part and parcel of it, but also the person living with dementia. And often they have said, oh, well, I can't do that. I just don't have any kind of artistic skills, but they do. And they come out of there with a portfolio that is amazing. And sometimes you even see the creations on the walls. It's a very small group that we can accommodate because the artist studio is very, very small. And so that goes on, that limits the number of people. So Chris is actually in the second person in. I know Helen was talking about her earlier. Education, the Alzheimer's Society is really great of bringing out education to our program. I should mention too, we used to have, many years ago, we had the Minds in Motion program through the Alzheimer's Society, and that's not available in our community now. We just finished having a section program called Let's Move It. And it was one of the ones where they come together and they do physical activity by a trainer at the local Tri-Leisure Center. So, and that was very well received, and I know they want it back. So we'll have to be looking at that for the future. Another thing that we have done and to increase the awareness about dementia and making that people feel comfortable with dementia is shifting perspectives. And generally during January, we have had meet and greet at the Tri-Leisure Center. And what we would have is all the agencies that are part and parcel of our Westview Dementia Collaborative would come with a display, and they would talk to the people that come in. It was just drop in, you could come in and talk to those people, and away you go. So a little bit incorporating what Drumheller does with their seniors conference, only in a smaller scale and not with the lunch and all that kind of things. But it is definitely a good way for people to connect with individuals, the health professionals. We have a list of the different agencies that are part of Westview Westview Dementia Collaborative, and at the end of the slide, so you'll see what that is. One of the things this year, we're doing a little bit of a shifting with what we're going to be offering during January for Alzheimer's Awareness Month. And we have an artist coming in, or one-man act, and it's called How I Met My Mother. And right now it is probably about half sold, and we hope that it will be sold by that time. But I'm looking forward to it. And that's actually, in addition to the performance, there are going to be displays out there similar to what we did with our meet and greet in the community. So we're looking forward to that. Something different, something new. One of our individuals in our community would really like to have Jan Arden come, but she is around $10,000 or something like that. So we don't have that kind of funding. So we're going with this young fellow that is very entertaining, and I've heard good reviews from him. On to resources that we have, community resources. We have several. Through the Dementia Collaborative, we work together for a sheet that is in the upper left corner that outlines all the different resources. And some of the resources that Kim and Amanda talked about are on there. So because we have them in our community, we don't do those kinds of things with our programming, but we do have a sheet that we give away to individuals, and we've had it sent out to a lot of different agencies. And that's also one of the ones that's included in our Care Partners resort package. the dementia service navigation, a little bit about that. And then also down at the very bottom, we have something unique. We call it our wheel. And what we did was we had a grant and we developed this wheel. On the wheel, it has how you can help with someone who has dementia. On the back, it has resources, community resources that you can access, and also like 811 for Health Link. And also, if you can see that little wedge that's there, what we came up with was a variety of different walks of life that people have. And so this was for, sorry, I can't read it there, federal and provincial governance. And this is some ways that the federal government or the federal MPs or MLAs can do to promote awareness for dementia. And there's also different ones all the way around, from your community to volunteers, etc. Small, easy to do tips if you're coming to speak with someone or visit with someone that has dementia, or if you just want to know, what can I do as a citizen within our community to help promote the awareness and the comfort zone for people living with dementia. So this has been well received. We have well over 500 of them distributed around our community, and we keep getting requests from people to do it. We don't have a grant right now to make any more, but you never know. So successes and challenges. Successes to me are the connections that people are making in between care partners and also the people living with dementia. It's so heartwarming with our Trail Explorers program, where they go for a walk around the community to see the people living with dementia go off when they're doing their chatting, and where the care partners are standing back and they're doing their own care, communicating in between each other. We have trained volunteers that have been with our Trail Explorer program since the get-go, and they come and lead the walk every twice a month during the summer months. So this is a group that we're out on our walking program. And another thing that is really important for me and for everyone and the volunteers is the smiles afterwards, and the comments about, when's the next one? I want to come back. Can you give us a sheet? So I have a sheet that I give to them quite often. Our key learnings is, I guess my big one is, don't give up. There are people out there that will be coming. And even though sometimes our groups are quite small, they're still valuable. If you make that connection in between one couple, that has been worth the effort to come together with the different programming. So this was one of our walking groups. We walk different areas around the area. So we try and promote awareness, promote to the general public, and that's why we have our programs out in the community, just like what happens in Drumheller. We want to get people out in the community doing what they're comfortable with, and within the families. And we need to know about their diverse needs and what are their needs, and that's where one of our people on our community, on our connections, is the Westview Primary Care Network, and they are really great at having that navigation tool in order to help people to get around and learn a little bit more about what's available in their community. So what's next for us? Well, the stars are the limit, and I'm telling you, through the connections that have been developed through Helen's programs, you gain nuggets of information and good ideas from other places. I've written a couple of down from Kim and Amanda as to things that I would like to try. So we network around the community or around the province, and I have a couple of things that I'm going to be starting or trying to get going within our community down the road. So what's next? Who knows? We're going to go with whatever the community, well, and within budgets, we're going to go with whatever the community would express their needs. And actually at the last Move It session, the one gentleman said, well, when's the Christmas social? And I thought, oh, we've got to get that going. So they want these things, they want to connect and they want to be together. So acknowledging these are the people that have been part and parcel of our Westview Primary Care, our Westview Dementia Collections. And all of them have been part and parcel since the get-go, which is really encouraging because that's what we want to do. I should mention too, with what's next for us, we're talking with our group, do we expand the scope of what we're doing beyond dementia? Do we expand it to the seniors 55 plus, similar to what is happening in Drumheller? And that will probably bring in a few extra people that can network with other individuals and support each other. Even if they don't have dementia, they could support each other in a lot of ways. So that's a quick overview of what's been happening in the Westview Dementia Collaborative. And I must say that my heart is warm every time I'm part and parcel of one of the programs and see the people so happy. And it just like Kim and Amanda, those smiles and the thank yous are worth a pot of gold to me.
Thank you so much, Sharon. That was difficult for me to jump in there in the middle, but and also to Kim and Amanda. And thank you for letting us share about our work.
Thank you, everyone. Thanks, Helen, Kim, Amanda, and Sharon. Colleagues, if you could share your appreciation for the breadth of the team. I also want to apologise to you guys for some technical glitches we encountered during your presentation. Sorry for giving you an extra challenge there. That wasn't deliberate. We were encountering some connectivity issues our end, so apologies for that. Okay, let me check here in the room in the pavilion in South Wales and online whether anyone has any specific questions they want to pick up in response to what you've heard. Wait for the roving mic to come around. So, okay. Bill, you've got a question.
Hi, I'm Bill Clore. I'm the chief executive, one of the health boards. It's lovely to hear the body of work and extremely impressive that you can see how much it means to the people who are on the receiving end of it. I wondered, well, there are two things I wondered. One was you mentioned social return on investments, and also you mentioned that there's quality of life benefits and also savings for the health system. I wondered how the funders of your projects have reacted to that, and that means that there's now going to be a continuous funding stream for your projects. That was one question. And the other question is that, which is probably related, is that do you see some of these programs becoming self-sustaining within your communities? Because obviously that would be the ideal situation.
So, and the guys, I know when you caught that, so there's two parts of the question. One was around resourcing and sustainability of funding streams, given the evidence base that we've developed already. And then maybe tap into your personal views around the extent to which the programme you've described could be self-sustaining as it moves forward.
Sure. I'll take a stab at it, and then if the others have things to add, that would be great. So as we were saying just at the beginning, one of the things that's happened as our initiative has grown, there has been other initiatives within Alberta that have grown alongside, and we've talked about Healthy Aging Alberta. The government of Alberta is actually providing funding through that nonprofit organization for things like the in-home help support, the snow shoveling, the meals programs. And so that, and some of that also can be a coordinator role for all of those things. So that helps to really build sustainability within there. We are also hearing within our government that having supports for people living in the community is a priority, and wanting to see people aging in place. As we know globally, that's the movement, that's the push that is out there. We don't have enough spaces within facilities, and that's not where people want to live either. So we're hoping that those resources continue to grow that way with it. But it also, a big part of it has been leveraging what is there within the community. Kim and Amanda's example of the theater folks who have taken that on, adapted what they do, but they've actually brought in a new audience to their theater, and that has helped them as a business with it. So that's some of what happens. It's new resources coming in, but also leveraging what is already there. And that's what happens when you bring those different sectors together, which I think goes into that self-sustaining part of it. It's the more, the broader the network and the deeper the network that you're developing helps you to build those self-sustaining supports within there with it. So I think the two are really closely related. Does that answer it?
Yeah, and thumbs up from the questioner, so thank you for that.
Thanks. Yeah.
Can I check if there are any other questions that are online or in the room? We have one comment in the chat box, and so really pay appreciation to the work you're doing. We've got one of the commenters who's doing a bit of PhD research. Exploring loneliness in the role of the community in rural areas as well. So there's a lot there that you've covered in your presentation this afternoon that you can take away and reflect in your own work. So there's a big thumbs up and thank you for what you covered in that conversation.
Thanks so much, and please reach out with any questions. We'd love to answer them.
Can I just thank you for the early start that you've created today? Obviously, we're several hours ahead of you with, so really appreciate you joining us today.
Yeah,
thank you.
It's been great. Thank you. Bye-bye.
Okay, it's time for a short break. I'm going to suggest, if possible, that we can reconvene at 4:05. So I am 3:05. That's a very long way. 3:05. Apologies for that. I'm just mindful we've got the Chief Executives panel due to commence after our break. And we've got two leaders from our health board serving the area with us in the room, and we'll have Carol Schillermeyer from Recordiad joining us online. Unfortunately, Carol does have another commitment that she has to attend this afternoon. So if we can be prompt at our return in 4:05, that will allow Carol then to kind of her thoughts that we should all be here with us before we move on to film for Alvar and Kilbright for our student conference. So if we can reconvene at 5:05. Tables for those in the room here, and I think those of you online have access to these also. I'm going to just draw your attention to the QR codes you have available. So we really appreciate your feedback on the content of today's programme and the way in which we've structured it this year. Your feedback is critical to the way in which we shape these annual conferences. So if I can draw your attention to the QR code, please take the time to complete that. And we really want to be feedback. Thank you. Okay, thank you everyone. If you can take your seats and regather, both here in the room and online. So we've arrived at the final plenary session of the day, and I'm delighted to welcome some senior leaders from our local health boards serving the Mid Wales population. So we have Carol Schillermeyer, Chief Executive of Metropolitan University Health Board. We have Professor Phil Clerk, who's the Chief Executive of our University Health Board. Phil is also the lead Chief Executive for the Mid Wales Joint Committee Programme, so he may well share a dual perspective on our work today. And also I'm delighted to welcome Dr. Kate Wright, Medical Director from Paris Teaching Health Board. Kate is also the chair of the Mid Wales Joint Committee Clinical Advisory Group. So again, she has her own perspective to share. So the way this next session is going to work, we've asked each chief executive just to share their thoughts and perspectives for 15 minutes or so each on, to some extent, the journey so far and achievements maybe that have been progressed. But as importantly, I guess, really key for them to share their perspectives on the journey ahead, and reflecting then on some of the things that we've heard today. So first up, I'm delighted to invite Carol. Carol's unfortunately been able to be with us in the room today due to other commitments. We'll run with Carol's presentation first. Carol, if we've got time allowance, I know they've got some commitments that you need to follow on with. We will check to see if there are any particular questions that colleagues in the audience wish to share. If time runs against us, don't worry, you can always finish those questions and send them all, and then you can respond in due course. Yeah. Can I just check that the sound quality is okay at your end?
Yes, and can I just check that you can hear me okay?
We can, sir.
Oh, fabulous. Diolch yn fawr. Thank you very much indeed. And it's a pleasure to be back at the Rural Health and Care Wales Conference. I look back and think, goodness me, how many years have I attended this conference previously in my role in Powys, but I think this may well be my third event here from a North Wales perspective. So good to be back with you, and I'm sorry I'm not there in person in the room. And yes, you're absolutely right, I have another commitment, I'm afraid, at 3:30. So in the time that I've got available, I thought I'd just share a few reflections. So what's happened over the last year or so, and what are we looking forward to as a community across the Mid Wales region. And I start with something that I think has been long in the development and will have a really significant impact of change, and that relates to our work collectively over the years to support the development of a North Wales medical school. And it's about a year or so ago now that that was opened, and the cohorts of students coming through. And when I reflect on that, it feels like a game-changing opportunity for us, not just around potential supply of a future workforce, of course, although that's a pretty big draw, but because of the ability to influence language and culture in care. And that's been a really strong feature of Bangor University's offer in partnership with others. Just this morning bumped into a colleague who was instrumental in the development of the North Wales Medical School and reflecting very positively on the year that has happened. And of course, if I spin forward, when we make significant step changes, it often provides a platform for the future, and without getting too carried away, to see whether the success that there's been around the medical school can possibly translate to dental school. And we've got the pharmacy school here and now, so that has already moved significantly. The reason that I talk about that as a game changer is that will have an impact right the way across rural health and care in Wales, and there'll be people in the audience, I'm sure, who have contributed heavily to that success. So the second area that I wanted to consider and reflect on in terms of achievements is really thinking about planned care. And people might think, oh, why is Carol talking about that? Because she's got some of the biggest challenges on timeliness of planned care that there are in the rest of Wales and even beyond. Well, the significant progress that has been made, a 500% reduction in our very long waits and 60% reduction in over 2-year waits, has spurred on, I think, a realization that the traditional approach to planned care just isn't delivering either for patients or for colleagues, and therefore just considering the different ways of operating. And I'd be really pleased to see our Llandudno elective hub, a cold site or a purely ring-fence site, now in the final stages of development, where we will be first caring for people going through joint replacements, and really challenging our ability to see higher level patients, higher need patients in environments that are not at a DGH. So that's both cultural system and process change. And I'm struck by how entrepreneurial and innovative teams can be when faced with a real challenge, such as a significant sort of backlog and cohort of patients. That will spur us on elsewhere in Wales, I'm sure, as colleagues in South Wales also get to grips with elective hubs and separate services away from district general hospitals, and more to come on that when I focus on the future. And then the third element really is the community, and really focusing on different models of care. Necessity is the mother of all invention, and how we use problems to help find different solutions. And a simple but highly effective one developed in rural North Wales and spreading across the organisation. A simple concept of community large-scale clinics or events that were held for physiotherapy, for example, bringing together a broad range of partners in one place, inviting very many people to engage with the services, including clinicians, but more importantly with those community services that we know are at the heart of communities right the way across Wales. And if I may put a plug in for the nifty 60s in Ynys Môn, the impact that community development is having on people in the local area is really significant. So an achievement around engaging even more than we were before in different models of care, and that gives us the confidence to move forward. If I have a bit of a focus to the future, then there's a bit of a theme that flows here. One relates to how we grasp the nettle to make a shift from a secondary hospital orientated to that of community. Now, I know that in rural health and care conferences, we have focused really significantly on that over the years. The ability to be extremely resourceful in highly rural areas is astounding. Yet the facts of the matter are that we still get measured very much on access times in hospital-related care. So I'm really pleased to hear the new Chief Medical Officer talking about a revised new outcomes framework for Wales that will be centred on community by design. The reason that we're so pleased with that approach here in North Wales is our focus as an organisation on developing a new strategy for the next 10 years, and in particular clinical services plan. Our colleagues in Hywel Dda are leading the way in the approaches to service change. It is tough for sure, but hats off to Phil and the team for really grappling with the key issues. And we are learning from you as we move into this coming year. What we do know is that current models are not sustainable. And we also know that people get very nervous about even thought of change. So how we work with people, how we redesign a system that has people and communities at its heart is going to be our key both challenge and opportunity here in North Wales to do things very differently. Our other focus for the future is really on enabling digital tools, and I'm really pleased that from a North Wales point of view we have been at the forefront in implementing systems that help to modernise practice. So radiology system recently, a very hard implementation, but that will support clinicians and patients actually to access more modern care. We are midway through the implementation, just done the procurement on the mental health electronic patient record, and we're very keen to move forward with a more combined electronic patient record for the future. Along the way, the ability to digitize and to utilize AI in our pathology services, for example, leading the way on that. So our future plans must focus on giving people the tools to do the job, grappling with the fifth industrial revolution of AI, and drawing all of those together so that they can complement rather than replace the people that the NHS is really all about. A couple of other big ticket items just to finish, and whilst we are focusing on rightly on services and populations, as a health board we are improving our effectiveness as the largest public sector body here in Wales, both in the health sphere, but actually as a major employer and a contributor to the economy. So these sort of wider social contributions are very clearly on our mind as we look to play our full part in our region and beyond in terms of the economic prosperity of Wales, topped with the language and cultural aspects that make us a unique nation. So we've got a lot of work on our hands. We've got a growing momentum, I'm delighted to say, but we will continue to look out at our colleagues both in the health service but also beyond in other industries and in our university sectors, of course, to help us with inspiration, check, challenge and evaluation. So I think I'll draw it to a close and say diolch yn fawr iawn. Thank you very much for inviting me to say just a few words about some of the achievements and opportunities ahead here in North Wales.
Yeah, Carol, thank you very much for that. Can I just check before we move on to other colleagues on the panel whether there are any specific questions colleagues either in the room here or online wish to pose to Carol just before she has to run away? Okay, thanks, Carol. Thank you so much. I'm sure once we've gone through the discussions with Phil and Kate, there'll be some general issues that may well crop up. And if there's any specific that's pertinent to the Betsy patch, then of course we can feed that through to you. So really grateful to you for being able to join us this afternoon and taking the time. I'm sure colleagues will appreciate you leading me. Thanks very much. Okay, next up we have Professor Phil Cynhadledd. He's the Chief Executive of Arloesedd University of Yes.
Gwrando, diolch yn fawr am gwahoddiad I siarad prynawn yma. Diolch hefyd I Anna am drefnu'r digwyddiad heddi. A diolch I chi gyd am ddod heddi. So for those of you who speak English, don't speak Welsh, that was Welsh. And for those of you who speak Welsh, dwi'n dal yn ddysgu Cymraeg. So I'm still learning Welsh. Trying. So look, great to be here. And I realise I'm just the warm-up act to the Powys for Kate, so I'll do my best not to go on too long. But this is a great event. I'm so pleased to be here. I really am. And I think, you know, the learning and sharing that we can do through this event, not only just the people here, people online, is just so impressive and important for us in our rural community. So tribute to Anna and the team for really making this happen. And in fact, if you haven't seen the posters, I was having a look myself, have to say there's some really impressive pieces of work there. And we do sometimes get embroiled in our minds in just thinking about the challenges that we have and the kind of deficits. But I would say that we have some amazing assets within our communities and some amazing strengths that we need to build from. And I think we sort of heard that from the Alberta presentation. They were very much building from the strengths that they had. And I think we have to continuously force us back to think about that, because sometimes we do think come from a deficit point of view. Anyway, from Hywel Dda perspective, we've made some significant progress, I think, over the last couple of years on some key performance indicators across our patch, but which would benefit people from Mid Wales as well as it would within Hywel Dda. So our waiting times, we delivered the national waiting time target for outpatients and also for planned care. Now that's a 2-year waiting list, so I appreciate there will be people weren't exactly dancing around celebrating this, because 2 years is a very long time for people to wait, but it took a huge amount of effort. We had people waiting 4 years when I started, and it is a huge effort from the team, which includes Keith, so thank you, Keith, but also all the clinicians who've really made that happen. And I think also, I understand we're on target this year to deliver the target for outpatients and planned care. Also, we've made improvements in cancer care. We compare very favourably against the rest of Wales, and we're improving still for the rest of this year, we hope. And in urgent and emergency care, there are less people waiting for ambulances in the community than there were. There are less people waiting outside our hospitals in ambulances than there was just 3 or 4 months ago. It's really tough. We know we've got to do a lot more. I know from listening to people, in fact, I only have to listen to my neighbours or people in my house about the kind of patient experience that people are receiving. I know we've got to do a lot more, but we do feel we're on the right trajectory. We are improving. And actually, the consultation and engagement process we've just had has allowed us, including me, to sit around tables like this, listening to people from deep within communities about the kind of experiences that they have with the health system and the things that are important to them. So I've really valued that. Anyway, I do have some slides, and I'm just what I have taken on the Chief Exec lead very recently for the Mid Wales Joint Committee, and I'm delighted and proud to be the Chief Exec lead. So there are a few things I wanted to present where I think we've made progress, and I think it crosses over a few different health boards. The first one is about the cancer unit in Bronglaes. I think, that Larry Day unit development, I mean, it has been long awaited for those of you who've been trailing this, but it is there, and it's a fantastic development, better for patients, better for staff, a real upgrade in our facilities for Mid Wales patients. The other thing is building on the colorectal services that we've developed in recent years at Bronglaes. That was important because it safeguarded acute general surgery at Bronglaes, because the colorectal surgeons generally do the acute surgery. So that, again, that's a step forward. Building on that, we've had our colorectal surgeons doing clinics in Newtown, in Paris, working with our colleagues in Paris, which I think is another brilliant development and means that there's enough activity for our surgeons. And then you'll see there's one there which is a joint project around, I'm not doing your whole presentation, Kate, but there's work there around cross-border workforce, around our healthcare support workers, which frankly are the backbone of the care that we provide within the community. So there's a development programme for them. So I suppose the issue sometimes is that development is only given to sort of senior clinical leaders. So I think this is an excellent programme of work. And you'll see we've got plans to expand that to Betsy Cadwaladr. And then the School of Nursing, Carol talked about the School of Medicine, which is a great development again for us for this area. And the hope that we may get a dental school in collaboration between Aberystwyth University and Bangor University, that I think is certainly seems to be a chance that that's going to move forwards. In terms of nursing, you'll see there the stats. We've got 20 more nurses in Hywel Dda and 4 in Powys, another 76 coming off next year. That's a great pipeline for us in Mid Wales. And we know that the only way really to get a sustainable pipeline of staff is if they train within our area. Plus, it means they have a proper understanding of the kind of communities that we serve. They're embedded within them, and they get trained in that kind of environment. So I think all of that is excellent. You can see there's 2 areas around urology where we've made some progress for people. I think that's through the Mid Wales Joint Committee working it through, to be fair, the work of Kate and the Clinical Advisory Group. So I think those 2 areas around trial without catheter, where we were trying to go for things which affect the largest number of people, and try to go for things where people were giving us feedback that it was problematic for them to get access. So hopefully we believe this has been beneficial. I'm going a bit more rapidly now, a bit pleased to know, Anna. In terms of the work that we're doing at the moment, dental's always something that comes up, you know, certainly in my mailbox, certainly in the politicians' mailboxes, I know, and certainly for all of you who live in this area. So you can see there's work on dental services, including paediatric general anaesthesia, stroke services. I'm sort of expecting I might get a question on that later, but there's a strategic service change programme around stroke services under the auspices of the Mid Wales Joint Committee, which is important because it's not only Hywel Dda that has a clinical service programme at the moment. You know, there are other health institutions in England and Wales that are looking at their stroke services because of the advancing evidence, changing evidence. I've mentioned colorectal. We're just exploring the feasibility of how, if it's possible, to expand that service. And then there's dermatology, which again is a service which affects a lot of people. And, you know, travel is a big issue for Mid Wales. And the more we can get a robust service for people in Mid Wales, the better. So you can see we're working on that. And just to mention the Sexual Assault Referral Centre, that's another development in Aberystwyth. Of course, we've got the university there as well. So this is an important service which has been commissioned, and we've got capital from Welsh Government. And then the Cardigan Estug, or the Ceredigion thing, for those of you from that area, we've had a same-day urgent care service, so it's not just a minor injury service, it's also an urgent care services for minor illnesses, an urgent care which is run by nurses, it's not run by doctors, and it's very highly regarded if any of you had experience of it. I know the push is for us to open it at weekends, and of course we're looking at whether that's possible over the winter months. So the last thing I was going to say, yeah, better be. The last things I was going to say, oh, actually, were two areas. One is about our clinical services plan. These next 2 slides are about the big clinical services plan that we've engaged and consulted on over the summer months. So that was 9 different clinical services. And relating to what Carol Shillaby has said, of course, we do, all of us in our health boards have unsustainable clinical services, which frankly, if they're unsustainable, means they're not providing the reliable quality of service that we would want for our population. And frankly, that isn't pointing at the clinicians or managers trying to deliver those services. It's just really difficult for them to deliver the expectations. So, and for Mid Wales, it does mean that we're looking at services where we can bolster and improve, and other ones where we just can't. And we're just trying to manage that balance for people. Happy to discuss that further later. You can see we've had a huge response to our consultation, over 4,000 responses, 287, I didn't realise it's got that much, 287 different options which we're trying to manage. We've got a independent company helping us look through all that data. I think their point was that they've never seen quite so many responses or different options. So we've had a great response to our consultation, which is fabulous, but we are going to have to and we've had to push back the date when the board can make a decision. So we're having to go through a period of conscientious consideration. So if you think we've gone very quiet about it, that's not because we're not doing any work on it. We're doing a huge amount of work on it. You can see there that we've had a lot of sessions with all of our clinicians, workforce finance teams. We've also got community representatives trying to make sense of all the different options, and we're trying to consider them carefully against our criteria. I know you need to be rapid. So we've got an assessment on the 19th of November. That's an important moment, but really because of the volume of information, we've had to push back the decision timeline for board until the 19th of February, when we've got a single issue board where we will consider all of the various options and come to decisions where we can. And we're not expecting it to be exactly the same as what was produced to the public. We're expecting us to be influenced by what came out of the public consultation and engagement discussion. So perhaps I'll leave it there on that. The only other two quick things, and they will be quick, is that we are re-looking at our strategy in Hywel. We agreed our strategy back in November 2018. A lot has happened since then, including COVID. Plus, would you, I mean, 2018 doesn't seem a long time ago, but it is 5 years ago, you know, so we do need to relook at our strategy. But what I would say is we'll take the learning of recent times, we'll take the learning from COVID, we'll take the learning from what Carol was saying about digital AI and tech, which we are really trying to harness. We don't want to be left behind. And frankly, the public would expect us to be harnessing that. People don't want to access services, particularly younger people don't want to access services like they used to. Got to think of digital inclusion. Not everybody wants to do that, but you know, we are really looking at digital AI tech. Two things that won't change though is we are committed to move to a much more social model of health and well-being, because frankly, the NHS, everything it does, all the money we spend is only responsible for 15% at most of population health and well-being, and yet we spend over 50% of the budget in Wales. So seriously, we have to move to a much more social model of health and well-being, and we're trying to push that. We've set up a Centre for Social Innovation with University of Wales, Trinity St David's. We're trialing all sorts of things, but this is about activity deep within communities, how we engage with them, how we support communities to be self-healing, resilient and connected. The challenge for the NHS is how does it do it? Because in the end, the NHS tends to try and take over. And it's really tricky for the NHS to know how to be a helpful outsider within communities. And my last thing is, the other thing that isn't going is the commitment to Mid Wales. We won't change that in our strategy. We know how important bronchitis is. We've seen some serious recent developments. So I can say we've just appointed a new chest physician at bronchitis. That means we've got two. We've never had more than one. It used to be Alan Axford. Those of you who remember Alan, I was with him yesterday. You know, with that two it's so many, but that is a big step. We've got 3 extra A&E doctors at sort of registrar kind of grade starting. We've appointed them. That is another big step. We've not had that before. And we're just about to appoint, hopefully, a new A&E consultant, which will take us up to 2. So the trouble is that in the press, you'll see downgrading. I will always be talking up bronchitis. Okay, there'll be other people who talk it down. I won't be doing that. So I do believe we're making progress. But anyway, I better stop talking about it. Look forward to the questions.
Thank you so much, Phil. What I'm going to suggest, we'll run straight on and lead on with Kate's presentation, and then we can take some questions in the round for both Phil and Kate afterwards. So I can welcome Dr. Kate Wright, Medical Director for RHCW Health Board. Thanks, Kate.
Thank you, Keith, and good afternoon, everybody. So it's my very great pleasure to be here. Hayley really did want to be here, but unfortunately she's been called to something that she couldn't get out of, so you've got me instead. There's quite a lot to talk through, so I'm going to ask that if I'm running over, you rugby tackle me to the ground, and I'm going to go as fast as I can. Which one's move on? Thank you. We were asked to talk about achievements. I went out to our team to say, tell me what everybody's been doing in the last year, and I've tried to take most of it. I can't go through all of it, but what I'm just immensely proud of, you probably all know Powys, we are geographically massive, but in terms of staffing, and especially clinical staff, really tiny. Times are hard. We're in level 4 escalation for finance, which is really serious. We're in normal escalation for quality and safety and performance. So that's all going well. So life is hard, but in spite of that, I've just been really, I knew this, but when you see what the work of our tiny teams has been, where they're all trying to deliver on the money, trying to deliver on performance, and yet at the same time, we've got tiny teams who are carrying forward lots of quality improvement projects, which is all aimed at improving resilience in communities and strengthening our communities' sustainability. Our ethos is to provide as much care as we can safely and sustainably within Powys and within the communities. And hopefully there's a snapshot here of all the work that people are doing. We do also, obviously we're working in the Mid Wales environment, and Phil's covered a lot of that, so I'm not going to go over that again, but just to say that that is a really, really important piece of work, because the shared learning and the shared support and just a shared understanding of the problems we're all facing. We can often find solutions just by having a conversation, so that's really important work as well. So just I'm going to rattle through a few of the things that are happening in Powys at the moment. And these things will be happening in other health boards as well, I'm sure. But we've successfully introduced first contact practitioners in primary care. That started a while ago and has been rolled out really rapidly in terms of physio and audiology, and is having a really positive impact in taking some of the pressure off our primary care colleagues, improving outcomes for patients, and also reducing the numbers of people going into secondary care. We've got a really strong community frailty project which continues to grow. So whereas comprehensive geriatric assessments are traditionally done by secondary care clinicians in hospitals, then we have allied health professionals carrying out them in the community, screening patients, starting interventions, and we know there's evidence, and strong evidence, that that improves outcomes. So that is up and running, and we will evaluate as we go. We've got an MSK physiotherapy initiative in leisure centres in Welshpool and rolling out to Brecon. The reason we're doing that is just to take people away from hospital environments, saying that this isn't all about medicalisation, that this exercise is important, it's part of normal life, and really just to demedicalise some of the treatments we're giving, and that's working really, really well. We've introduced 1+2, which is improving access for our mental health patients, and the public health team, along with the rest of the execs, we've got a really strong ethos of pushing the left shift and pushing prevention. And it's tricky. You know, we've got twin track really. We're having to kind of accelerate on lots of here and now, lots of reactive work, but you've constantly got to have your eyes on the long term, the prevention, which will get us where we need to be in the end. So here are a few of the things that our public health team are working on. And I think this really, really jumped out to me when I saw this a couple of months ago. So we've had a problem. We know that intervening in childhood is really key. And the more we can intervene and support with our children will give us long-term improved outcomes, not just in health, but in terms of equality, etc., etc. So we've been stuck with increasing childhood obesity for some years, but over the past couple of years, we've seen a reversal of that trend. And since 2019, we've seen a 6% reduction in childhood obesity in Powys, which is the result of a lot of hard work, really multi-agency. So it's not just health, it's working across all the sectors, education, social care, and just within communities. And these slides, I think, will be circulated, so I won't go through the detail. I think it's a really good example of how communities working together with some coordination can start to improve health outcomes. Another piece of work that the team are doing is to look at vaping. So there's a big piece of work looking at vaping in young people, and that work is up and running and is being evaluated. If you do want to look at the slides, there's a little video, which there's a link which will tell you more about it. There's a lot of work going on falls. So not just we're working with partners such as St John's Ambulance, but also, again, led by our therapy team, we are screening for falls in the community. There's a very simple app that we've developed, which actually is the lion's share of the complex geriatric assessment. And that is allowing us to screen early and is already evaluating to be having a positive outcome in terms of reducing falls and reducing outcomes. So teledermoscopy is one of the initiatives that's been put forward by the MAG. We introduced this a couple of years ago in Paris, and so this is GPs with cameras taking images of skin lesions, whereas traditionally they would have been referred in and waited for an outpatient appointment in secondary care. Now a photograph is sent, and this is, I just think this has had a massive impact. So what we know is that 15% of the referrals are rapidly upgraded. The GP probably wouldn't have sent an urgent referral, but 15% of those referrals have been upgraded for an urgent cancer review. About 40% of patients don't require any face-to-face whatsoever, can be discharged safely with no intervention, and another 50% or thereabouts are going much more quickly straight in for a one-stop clinic where they probably have the lesion removed. So that had a really positive outcome. It's positive for general practice, it's positive for patients, and it's releasing capacity in secondary care. So a few more things. Let me just pick some of the antimicrobials. Absolutely have to shout out about that. We've been the lowest performing health board in Wales for some time in Powers. We were really working hard on it. We weren't shifting that at all. We've appointed an antimicrobial pharmacist in less than a year. We've now moved to the middle of the pack and are rapidly heading toward the top of the pack in terms of performance. So immensely proud of that and her work. She's put a lot of hard work and dedication in. What else? I'm trying to pick out the most important. There's work going on speech and language therapy, medicines management. We've got a dietitian working with the care homes, which we know improves outcomes and reducing secondary care attendances. COPD project starting. So we've got things going on everywhere, essentially. Risk of running over, so I'm going to keep going. We are at the same time doing lots of work really to try and sort of square up our systems. So we've got a virtual ward. Data is tricky. We've got quite a complex system. So we've worked with the LMC to update the supplementary service of primary care. So we're now getting much better information coming through from our virtual wards, which will give us a much better basis on which to learn and improve and develop. We've introduced a community treatment escalation guide. This is, for me, really, really important. This is about patients getting the treatment that they need and not getting the treatment they don't need. There was a secondary care document in Wales, but there's no primary care or community document. It is being worked on nationally, but these things take a long time. So working with the national team, we developed our own. So that has been rolled out successfully, and I think is now being looked at by, I think, 2 or 3 other health boards, which is really positive. We are a bit behind the curve in terms of fractional liaison. Again, we know that's another really important left shift, but we are getting up and running with that. And there's more work going on with St John's Ambulance for falls. We did, I must mention temporary service changes, so some of you will be aware of that. So last year we introduced some temporary service changes, which was reorganising the way some of our wards were working. So we had co-location of people who were ready to go home and co-location of rehab patients. That has been evaluated and is evaluated really well in terms of improving flow, improving access to therapy, and so reducing length of stay and reducing bank and agency use. So it's given us efficiency. So that, well, they are temporary, and we will talk about our future plans in a moment, and those plans will be evaluated further as we move into our next areas of focus. We've introduced digital flow systems on our wards, and importantly, our community paediatrics team has really struggled with the increased referrals for ADHD, along with lots of other places in Wales. So we actually put them into a sort of process of what we call escalation, which just means we put focus on the team and give them support, and that has allowed them to review their working practices. Not that much was wrong, it was just that the demand has completely changed. And there's a really good example of multi-agency working with schools, working with social services, working together, making sure the children that need the medical review, get the medical review. We managed to get our weights down. There's still a long way to go, but that's been really, really important work for us. Okay, future plans. So some of you will be aware we have a big conversation which we're calling Better Together, and it really is about being together. We've got our long care health and care strategy. We've been working over the past few years on, first of all, our accelerating sustainable model, and now Better Together. And this really is about working towards a robust, sustainable community model. It's got various pillars of work. Main ones at the moment are community model and mental health. Those are our initial focuses. We will be doing work and are doing work on diagnostic and planned care and women's and children's. The drivers of that, I think probably everybody, with no surprises, we have got fragility. We have got fragility in staffing, lots of banking agency use, which gives you concern about quality of care and efficiency. We have got a long length of stay, and that drives poor outcomes. So we know that the care we're delivering, in spite of everybody's best efforts, could be better, if we're honest. We've got fragmented teams. We've got lots of really, really brilliant staff, but they're working in tiny teams. And there is a need to bring people together so that they've got more peer support, but also that they're working in more effective teams. We also, with the tiny teams, and especially a very rural population, you can have difficulties with having a critical mass of patients to maintain clinical skills and wanting to keep people. We want to keep our staff working in rural communities, keep them motivated and keep their workloads up. And another driver, obviously, is that we are in level 4 escalation for finance, so we need to do everything we can to make sure we're working as efficiently as possible. So where we've got to with that is there's been a lot of work at pace. Based on a lot of work that had already been done, we'd already gathered a huge amount of evidence and spoken to lots of people. So we've had workshops right across with lots of staff, general practice, lots of all the important stakeholders, and we've gone out and spoken to our public. We've had some external experts who have been brilliant in coming in. We don't have many specialist clinicians in Powys, and they've been brilliant at coming in and helping us as critical friends and giving us really invaluable advice. And what's been really heartening to me is they're really, really invested in what we're doing, and they've been giving us quite a lot of their own time because they can see that what we're doing is important. So that's been great. So we've been through a period of engagement. There's a lot of work to do now to undertake more modelling, and the next steps will be progression to public consultation. We've got a long way to go. We know this is really, really important, and we want to do this properly. So we're looking at the moment about what timeframes that is realistically going to take, and we'll be telling people more about that as we move forwards. So I think that is me. That is me. Thank you very much.
Thank you, Kate, and thank you again, Phil. I'm sure there'll be some questions from what you heard, either in the room or online. Yeah, wait for the microphone to you, and then I'll repeat the question just for colleagues online, just before I hand the mic then to either Phil or Ashford. Okay.
So my question is about ABC. It's about boundaries, barriers, and collaboration. We've heard it's quite an operational question to a certain extent, and I appreciate the slides have been quite strategic. We've heard some really inspiring and exciting examples today of things that are happening across rural Wales and obviously Scotland and Canada. So we heard from Adam, who talked about remote medication and looking at setting up a dispensary in Dolgellau, which is fantastic, but will people from the country be able to access that going from Powys to Betsy? We heard from Mary, who talked about an integrated care fellowship in Howell, but she very much focused on Howell. Is that being rolled out? Are there opportunities for other parts of the Wales? We heard from Joanna about the NHS app, which doesn't talk to England. So again, another border issue. So there are some real practical realities and challenges for patients and families in rural areas. And so really that's the sort of question I pose. I think the other question I pose is, you know, potentially having heard what we've heard today, what the role of the Middle West Wales Regional Joint Committee is. We've heard from Veronica about the need for a rural health care equity strategy. You know, where does all of that fit together? How do we link it all up from a patient perspective?
Thank you, Katie. So hopefully you guys online will have caught that, but I'll just give the short version of that. So there's a question on barriers, boundaries, and communication in respective areas, and how we sort of make service accessibility across borders essentially. And then there's a supplementary question around the role perhaps that the Midlands Joint Committee can play in addressing that wider challenge we heard about this morning around rural health.
Oh. Yeah, thanks, Keith. Thanks very much for the question. I think it's a really good question, to be honest. So thank you for that. So boundaries, barriers, and collaboration. BBC, which is topical. So look, I think, and your point about what's the role of the Mid Wales Joint Committee in this. So I was thinking there's a few things. The first thing is, actually, and your other point is, how does it relate to maybe a rural health care equity strategy or whatever? I think the Mid Wales Joint Committee and also this organisation, you know, Rural Health and Care Wales, I think they promote the rural communities and the importance of the rural communities. I think that if you go back to Marcus Longley's report back in 2014, part of the reason for that was there was a feeling that there wasn't enough focus on rural health in Mid Wales. So I think that that point still remains. I think it's still important to have the Mid Wales Joint Committee and the Rural Health and Care Wales to really promote the kind of challenge. Well, I talked earlier about the strengths of rural communities and some of the challenges people face. So I think so that would be one role of the Mid Wales Joint Committee. I think the other role, which we see in action, if you look at my slides and Kate's slides and some of what Carol was saying, a lot of the progress we make is made together. It's difficult to make that progress if I just pick the dental or urology, or even the case for a medical school, dental school, nurse school, whatever, all of those things. We can't really make them one health board on its own. So we have to do that together. So where it comes to some of the things you mentioned, like remote medication dispensary, integrated care GP fellowship, or leave the NHS app in England for a minute. But the other two, I think that with the Mid Wales Joint Committee and, you know, Kate's, the clinical advisory group, we've got a much better chance of sharing than we would have if it wasn't there. The only challenge sometimes is that health boards have different priorities and are in different stages of their journey. So sometimes Carol might prioritise something slightly different to me because of our position, say, on plan care or finances or whatever. So but I think the Mid Wales Joint Committee and the clinical advisor group that supports it has a really key role. And I think with Rural Health and Care Wales, it does give us a chance for us to explore and look a bit more broadly. You know, we've seen today the benefit of having, I mean, I found it really interesting listening to Alberta, the Alberta experience, but all the stuff that's come today, I think inspires us to think a bit differently each time we do it. So hopefully that gives you a bit of my perspective on it. Thank you. The NHS app is another thing. England-Wales border, now that is more challenging, particularly when it comes to digital, because they will have their own views.
Because somebody, oh, yeah, I've got the mic in the middle. We'll go here and then we'll go to the middle of the room. So apologies for that.
I'd like to say a big thank you to Paris for actually setting up and making website. Just press the button. Sorry, I wasn't noticing.
That worked.
I'd like to say a big thank you to Paris for the things that you're highlighting today that are really good and making progress. Particularly in childcare and obesity being improved by 6%, that's wonderful. And hopefully with the vaping and the other things you mentioned, are really good progress. Progress takes time, and I understand that. But I'm going to go into a couple of things that might not be so happy, but I thought I'd start off with a good note, so thank you. It's interesting you mentioned about the audiology, and this week I had an occasion to be in Arloesedd and talking to veterans, and actually one person who's really struggling to get actual any support for audiology and becoming very depressed. So actually it's an ongoing thing, that's a real problem, so that I think needs to be reviewed and looked at. What's it, and I'm not going to be about individual cases, because we're looking at the whole different hours, and actually we need to make that. And the other thing is, the Better Together programme has been wonderful, and obviously it caused a lot of consternation with the co-location of rehab wards at the same time, and was then extended for the Better Together framework to go longer term. I think the local population deserve to have, you've highlighted that the outcomes and options is still ongoing and you haven't got data. But I think we need to make a date and let people know when that consultation is coming to an end and the time frame. You expect them to come to public meetings and they're getting less and less because they don't get any feedback. So I really would feel quite strongly about actually making a difference and telling people the time frame for when those options and those consultations will be out in the public domain. Thank you.
Okay, thanks for that. So again, just for the benefit of colleagues online, so the question around audiology service, and I must confess, the challenge around access for audiology services is not one that's unique to Paris. Did you not, unfortunately, but the same issues in Alvar, I know similar issues in Medicine, so it's almost a Wales-wide challenge from that perspective. And then there was a second question around the process, really, around the Better Together programme in Paris and the vision for the timeline around that journey coming to a outcome.
Yeah, thank you. Most really important questions. So on the audiology, then I'm just going to invite you to get in touch. So the answer I think is that with tiny teams, it doesn't take much to tip us over and one resignation. So I think that's what we're just looking at there. But if you want to write, then we can give you a clear answer to that. So that would be great. In terms of absolutely Better Together communication, where we are and the temporary service changes, then we had hoped to be able to be looking at going to consultation now. But the work is being, frankly, just much more complex. And we've had really good constructive conversations. But I think we have appreciated quite how complex the system is. And we've got to do this properly. So tomorrow we have a temporary service change programme board. I chair that. And we will be meeting, and for that very purpose, we have got a clear message. There is a clear plan, but we need to make sure that is right, and then we have articulated it, but we will re-articulate it, because temporary changes are never ideal, and I think we all appreciate that's not a comfortable place to be, and I think we'd all rather not be there. What I am absolutely sure and very clear on is, whilst this is going to take longer, they have evaluated well, but we continue to evaluate, and for me there need to be very clear mechanisms and escalation in place, such as if there are problems, then we look and we are brave enough to reverse decisions if it's not working. So, and that is my job, and that's what I will be doing. So that's where we are. But that's what I agree we need to be able to, and we will more clearly articulate As we speak, we are just in that period where we have appreciated consultation is going to take longer. Because we want a clear message, we're working through what that looks like before we tell everybody, if that makes sense.
Yes, they were told October,
I know.
November, but no, you may have articulated it amongst yourself,
Yeah.
but publicly that hasn't happened.
No, and that will be coming. It's kind of, it's sort of active work in progress, if that makes sense. So, yeah. I just wanted, in terms of the Mid Wales work as well, I just think, and the purpose of it, I just wanted to reflect the work that the CMO is doing and leading at the moment in terms of championing communities, empowering community care. And I think it's genuinely an exciting time. There is a renewed energy. She absolutely means business, as the people around her. And I think that will become a focus for us in the Mid Wales group as well. We have tried to keep the most focused and try to look at areas that we think will have most impact. But I think coming down the line pretty quickly now, we'll have some work to be working on together, which I think is going to be quite exciting.
Okay, we've got time to take one more question from the middle of the room.
Thank you. I just wanted to know that for the day today, for the fantastic discussions we had for the day. So really, maybe out of the next meeting, reflecting various recommendations. So I really like the encouragement and there are things that the yesterday and this time yesterday. So that looks to me like it's possibly when somebody which could be replicated in other parts of the research, depending on obviously how and where it can be, put into the study. But my thoughts are going to the demographic system. And the population is not currently the way what it was before, because I come from Gwelliant, so what's something like myself. So obesity is increasing, and like chronic medical diseases. So if you compare the rates of the cases to more in the US, they are like what is popular for putting more specialist care in the primary care. So having been could it be something which could be thought of the legislature, because the more we can provide more specialty, whether it means breaking the barriers and enabling specialist care, some innovative like you mentioned about the connectivity going to forest, so safeguarding. So I really like that as well. So someone has any thoughts, maybe just the line very close with that sort of sharing problem. Thank you.
Okay, thank you for that. So it was a question around changing the profile needs of our population and the challenges that poses for particularly where some aspects of specialist care are provided. Yeah, just to check on that. Those are the volunteer first, I think, starting again.
Yeah, I'll start and then maybe Kate can come in as Kate's medical director, although I am a doctor, so as it turns out. So look, I think it's a good point, actually, about how we blur the boundaries between our specialists and primary care. I would say that, and I'm conscious of Sue Fisher, that we're going to have some GPs in the room, it's quite a good primary care representation. I would say that when you look at the challenges that society faces around chronic conditions, dementia, end-of-life frailty, all of those challenges, and childhood obesity, that if you look at what the hospitals have to face and what goes into GP surgeries, actually it's most of all of those kind of things, and often, so I think in one sense, the community by design work that the chief medical officer is really pushing, I think is almost, that has to be the foundation of this, because how we have a really resilient community and primary care system, digitally enabled, I think will be the best way we're going to face the challenges over the next 15, 20 years. I mean, to sort of lower the mood slightly, 2044 is predicted to be sort of peak mortality. That's when the sort of baby boomers come to end of life. Now, that isn't so much the end of life issue. It's the fact we will have the largest number of older people alive and the smallest number of younger people economically active. And so the challenges society faces around that, I think we'll need much more connected, resilient communities, much more activated, and we'll need a really strong primary care and community service system. We just won't cope with it. In terms of where the specialists come in, I think the specialists are going to have to reach out in communities sometimes to maintain relevance, actually. I mean, I'd say that as a specialist, I'm a chest physician's background. You know, I think otherwise the alternative is, as you're sort of saying, is they sort of stay in the kind of ivory tower hospital and wait for the referrals to come in. I don't think that's going to work in the future. They're going to have to be much more integrated, much more reaching out into communities, particularly in a rural health system. And I suppose when it comes back to the Mid Wales Joint Committee, you know, Powys doesn't have a hospital. So the way that Betsy and Hywel Dda work with Powys is really relevant in that regard, how our specialists reach out, like you said, with colorectal surgery, for example. Anyway, Kate, I'll hand over to you.
Just one over. So just to follow on from Phil, then, so I was a secondary care clinician, I was an ED consultant for my whole career, and I find myself working in the community, and I think that's probably no accident, because I realised probably for at least the last 10 years of my life in ED that I was constantly looking to what was going on in the communities to be able to properly look after my ED patients as well. So I have one eye on both of them, and we know that when people get into hospital, they decondition. So I think we need to be doing everything we can, and the GPs in the room will know that they do whatever they can to stop their patients going into hospital. So I think it is a really, really important question. I think I've been working here for 5 years now, and I think what I've learned in that time is that there are some things we can deliver really well in the community and some we can't. And it's about playing to your strengths. It's about looking to see what you can do sustainably. And there are some key specialties that really lend themselves well to that. So I think also we talked about, I think it does need a change of resource. We don't have the resource we need. We would do more if we could. We need to measure more of what goes on in the communities to get that resource moved over, and I think that's coming, which I think is really heartening, and that will be a real enabler for us. So the answer is yes, the ambition is there. We definitely can't do everything. The challenge is to identify what we can do really, really well and what we shouldn't do, I think.
Actually, we'll read quick. One thing I did forget to say is that I think all specialist doctors need to be population health doctors. They can't just be thinking about the patient in front of them. It'd be nice if they could think about the patient in the waiting room, waiting to go in to the outpatient room. But actually, really, they need to be thinking about the whole population of people, not just those on the waiting list, those who might need to be on there and need to be able to influence the need in communities. So I think actually, in my head, the most important thing is a change of mindset around our specialists, that they're thinking much more to population doctors. My view.
I think we need to show our appreciation to both Bill, Kate and Carol for them for taking the time out and sharing their thoughts with us this afternoon. Okay, that brings us to the end of day one. How to summarise that in 5 minutes. In fairness, Katie started to do a very good job of that in the preface to your question. So I'm grateful for some of her thoughts on that. So, excuse me, I've got lots of scribbles here in terms of the things that we've covered today. So, firstly, I do hope you've all enjoyed it. Yeah, and I hope you've been inspired by some of what you've heard through the course of today. So, our focus of today's programme was around how we can practically overcome some of the challenges of delivery in a rural environment. Yeah? I was mindful of the challenge that Dr. Chris Jones posed us at the start of the day, where it's really a call to arms in a way to move from a position of concept and ambition to practical examples of where we can start to overcome those challenges. And as Katie reflected this morning, some really good examples of work, not only in Wales, but in Scotland as well, how we can really make progress in developing and sustaining a high quality primary care workforce. Similarly, really grateful to Adam and his thoughts this morning and sharing his perspectives around the really interesting work in Betsy around access to medicines. And some really innovative thoughts there. The challenge, as I know Katie has raised this a few times today, and I think it's really pertinent. The challenge with those examples is scale, isn't it? How we scale up and deliver those services in an equitable fashion across border. Yeah, and I think there are some real challenges for us to think about as we move away from today around those issues. I think we've had some really interesting breakout presentations. Veronica, you really challenged us, I think, around to think differently about our approach to rural health equity, and that's certainly given me some pause for thought in terms of our approach there. Derek, I think, as Derek talked about the role of health pathways and the positive impact they can have on delivering consistent rural health and care. We had the West Wales Neurology, Neuro-Oncology team talking about really innovative ways to deliver care for patients with particularly complex needs in the community setting. And I know there was some very positive feedback on the work that they've been doing. Joe, Dylan, you talked about the role of the NHS app and how that can really be used in a practical sense to address digital exclusion. With its challenges as well, but clearly there's some real opportunities there. Joe talked about cross-sector delivery of preventative health interventions in Ceredigion, and Clive talked around the use of drama and movement workshops to really provide support to those patients with communication difficulties. We had a really interesting talk, didn't we, from the team in Canada, who really shared their perspectives. And I was struck by the point that Phil made earlier on. Sometimes we can get too focused on the obstacles, and they were a shining example really of where they worked on the opportunities to provide that cross-sector multi-care. Similar, really inspiring example then from the team in Lampeter, how they kept together and really found ways to mitigate those professional and organisational boundaries that can sometimes get in the way of really providing person-centred care. And I know that the team from Aberystwyth University have also shared their perspectives on the social prescribing work that they've been doing with the School of Nursing. So really practical examples of how we can possibly address some of those practical challenges to delivery that we set ourselves out to talk about today. Really grateful to Kate, Phil and Carol for their perspectives. Each shared, I think, certainly an evidenced positive reflection of the journey so far. But certainly I was struck by the opportunities for the future. Yeah, we heard about some really important enablers that will really strengthen opportunities for delivery of rural-based care. Carol talked about the School of Medicine in Bangor, Phil referenced the School of Nursing in Aberystwyth. Both Kate and Phil are actively supporting the job work that was mentioned around healthcare support work, delivery, etc. And then there's the AI agenda. And so there's a lot there, I think, that we can really take advantage of to apply in a positive, practical manner as we make further progress to achieving that level of equity that we would wish to see in terms of provision. That message was balanced, though, and there is a message of change. There are some elements of our service delivery infrastructure and models that if we're really honest with ourselves, not sustainable. Yeah, and I think you hear that each organisation is making a genuine, certain effort to engage with the population right across the Midlands area to have a real, honest conversation about what that means. Focus on where we can strengthen, yeah, and really go with that, but equally focus on those areas that may need to change. And we all need to engage and embrace in that conversation. The other thing that probably struck me was the extent to which each organisation is working in partnership. Yeah, so there's some real examples of where organisationally the health boards are beginning to break down barriers, and the same applies in social care as well. So I think there is a real learning for us to draw to take forward there. Was one other thing that I think that was mentioned, which is a really nice segue then into our programme for tomorrow, and I think Phil mentioned it. It's thinking about the social model of health. And our programme tomorrow is very much focused on the social determinants and non-political interventions that really drive healthcare and well-being in the rural environment. So I think that's a nice thing to focus on tomorrow. I really wish to thank all of our contributors and presenters today. Conscious it's been quite a long day, so I'm really grateful for everybody's contribution and the work that sits behind it, because that's the really important thing. We can celebrate those issues in an event such as this today, but it's the work that sits behind it, I think, that is really valuable and really proving to make a difference for patients within our respective communities. I equally want to thank all of you guys, yeah, for those in the room here today, Bill, and those online. Events such as this would not take place without your support. So I know Anna and the team are really looking for more engagement and support in this event. Once again, I'd like to thank the RHCW team for all of their efforts in planning for and putting on this event. It takes a considerable amount of work. I know the team have worked incredibly hard to deliver a program that hopefully meets your respective needs. Just a quick reminder, if you haven't done so, see I put the QR code on the screen there. So if you haven't completed your evaluation forms, please do so before you leave or before you take off online. We really would welcome your feedback. It's important that these programs are meeting your needs. So please give us your feedback for what you've heard today. And if you haven't done so, please share your feedback on the poster presentations as well. And I think we'll be looking to score that tomorrow. Okay, so if you haven't completed your forms, if you drop those in the collection box right at the exit, you can see them on the bottom way in the air there, and then we'll progress that work tomorrow. I think all that remains for me to say is thank you. I really do hope you've enjoyed the programme today. If you've got some distance to travel, please have a safe journey home. You can hear the rain, so the weather's not particularly kind to us. So please take your time and drive safely on the way home. If you've registered to attend tomorrow, then we'll do it all again. Yeah, so really look forward to welcoming those who registered tomorrow back here in North Wales for another exciting and hopefully inspirational day of discussion and debate around some of the opportunities ahead of us. Diolch yn fawr, really grateful to everything that you've contributed today. Thank you and have a great evening. Thanks.